Oh.
Recently just stopped. Looking after school to do something. Yes.
We have to wait just a moment. My TV decided to update, so.
No, I had school. Wait, what?
Those of you that are joining us virtually, please stand by. One of our tech components is updating, so I'm unable to bring you video. Good morning. Okay, we're going to go ahead and get started. You guys won't be able to see the screen right now, but everybody else out in virtual world can see. Technology. So you can't see up here. We'll bring it up as soon as this TV stops updating. All right. So we have a comment that I'll get to in just a few minutes once I can post it on the screen. How did you guys do with your homework over the weekend? Any questions on the homework? Anything you need for me to explain to you? You had chapters 5 and 6. 5 was on dementia. You're going to have a lot of dementia patients in your care, in your career. So understanding a little bit about dementia is very, very important. The biggest thing that I want you to remember about dementia. Good morning.
Good morning.
Our screen is updating. So once the screen comes back, you can pull we're live.
Okay.
Our feed is going out. We just can't display it on the screen.
Got it.
Okay, so let me kind of explain dementia to you really quickly. Did I give you guys the factory? Explain about the factory? Okay. So if I were to create something, invent something, and I wanted to have it produced, I would go look for a factory to make it. If I looked at a factory that was 90 years old, everything's rusty, the springs are broken, it only works some of the time, and the things it produces aren't great quality because it's inconsistent, that's one factory. The other factory is brand new, state of the art, everything works perfect. Which factory would I want to make my invention? The new one. Sure. So your brain is a memory making factory. When your brain is young, brand new, everything works really well, the memories that it makes are going to stick around for a very long time. They're good quality memories. But as you age, that factory ages too. And when you get into your later years, that factory is old and broken down, and the springs are rusted, and the gears don't work. And sometimes the things that factory makes, those memories, aren't very good. And other times it's just not working at all. So this is why you can have an older person that can remember the shoes they wore to a piano recital when they were 12, but has no idea that they just got back from lunch. And they'll ask you, when's lunch? Well, you just had lunch. You just got back from lunch. Why can't you remember that you had lunch? It's because the factory that makes that memory is just not working today. So you saying things like, don't you remember, is no help. That's like me going into that old factory and saying, why aren't you working? Well, it's clearly not working because it's old, not efficient. But we have to look at the brain in the same way. Caregivers get very frustrated with this, and they tend to say things like, I've already told you this a million times, or why don't you remember this? And that isn't helpful at all. They're not going to suddenly start remembering just because you want them to remember. Their factory isn't working. So distraction is the name of the game here. Get them involved in an activity because they're hyperfixating on something because they aren't able to develop that memory. So ask them a question about, their past, or get them to engage in an activity of some sort. Thank you, Jake. So just kind of redirect, and that usually will help. It may not help them retain memories, but it will help them keep from fixating on the fact that they don't have that memory. Does that make sense? Mm-hmm. So you are going to have, let me turn this a little bit for you guys. You are going to have a few questions on the written state exam that's going to be about this topic. And they want to make sure that you understand that this isn't. You guys ever been around a 5 or 6 year old? Mm-hmm. A lot of parents don't understand this, but 5 or 6 year olds will ask the same question over and over and over again to get under your skin. They will, and they're looking for a reaction. And this is where they're learning how their speech and their behavior can affect other people, right? So this is actually a very important developmental milestone for children. But for parents, it is a very annoying situation because you don't want to answer the same question over and over again, and you know that they're trying to elicit a reaction. So you get frustrated, and that's understandable. This is not that. Even though we have somebody who's asking the same question over and over and over again, remember, in youth, it's to learn how to relate to others, to elicit reactions, to manipulate emotions. And manipulation is a very bad word. We don't like that word, but you manipulate people all the time with the way you say things, right? If I want my husband to take out the trash, I might get really nice, right? So you learn these things in childhood. You learn how to relate to other people using your words, your tone of voice, your facial expression. And that's all part of that developmental stage. When we get older and we say the same question over and over and over again, it's not because of that same reason. It's because they truly cannot fix what you're saying in their mind to recall it. So same action, 2 different reasons. And we have to respond to those a little bit differently. Does that make sense? So chapter 5 talked to you a lot about working with dementia patients. But there's something else here that I want to talk to you guys about. We'll get to grades in a minute. There's something else here I want to talk to you guys about that's actually a very important component of this. So I want you to imagine for just a moment that you wake up tomorrow morning and absolutely nobody needs you. Nobody. You don't have to get anybody to school. You don't have to cook. You don't have to clean. You don't have to go to work. Nobody needs you. That day is all to yourself. Now you are kicking your feet and celebrating because, hey, I got a day to myself. And we would all love that. And you probably would do things that you enjoy. But after a week of absolutely nobody needing you, that feeling of freedom and euphoria starts to go away, and you start to look around like, really? Nobody needs me? Nobody? Nobody? I mean, somebody? And you start to question why you're even here. Because as humans, as part of a civilization, we rely on one another. We rely on each other for physical assistance, for emotional support, for companionship. And when all of a sudden you're no longer needed for anything, that can affect you. And depression can set in. You guys see how depression might set in? If nobody needs you and nobody is calling you, and it's like you dropped off the face of the earth, but you're still here. That is how the majority of the patients in long-term care feel. You know, at first it might be a vacation, but after a little bit, it's no longer a vacation. And you feel like maybe you really aren't meant to be here anymore. And that can lead to depression. Depression is very, very common in the elderly. We tend to kind of brush it off because, they're old, who cares? But it is important. Quality of life matters. It's not just quantity of life. So some of the things that we do in activities are geared toward making patients feel more needed. So in the activity room, we might have older women folding washcloths or matching socks, because these are things that they did as part of their household community. And it made them feel needed. It made them feel a part of, a contributing member to their society. So in long-term care, often we have repetitive tasks that older individuals can participate in. It's not slave labor. It's just to help them feel like they're part of the community. And they can choose to participate or not. Men generally don't fold washcloths and match socks, though. Men are generally more tactile. They generally do things with more mechanical type things. So in the activity room with women, a lot of times we will have repetitive domestic tasks that they can participate in. With men, we get a little more creative. One of the things that I used to have is one of those clear plastic shoe boxes with a lid on it, and I would fill it up with raw rice. And I always use jasmine rice because it just had such a nice soothing smell to it. And in that raw rice, don't cook it because then it gets mushy. In that raw rice, I would dump nuts and bolts or marbles in the rice and kind of shake it up. And I would ask him, can you find these for me? They're in here. They got mixed up. Can you find these? It's a very repetitive task. but it allows them to focus some of that time and energy and feel like they're a contributing member. Does that make sense? So this is what a lot of the activities that patients will be doing are geared toward is not just playing bingo, although that's important for socialization and for cognitive function, but it's also repetitive tasks that make them feel like they're contributing. Does that make sense? So activities in long-term care are way more than just parking somebody in front of a TV and letting the TV babysit them. That's not helpful. It's not helpful from a cognitive level. It's not helpful from an emotional level. And it's definitely not helpful for a self-actualization level. So as CNAs, you are expected to help patients attend activities, make sure that they're fed and toileted and dressed appropriately for activities. And we have to understand that these are very, very important things to their long-term mental satisfaction. Does that make sense? So chapter 5 talks a little bit about that, but I think that it could be presented a little bit better, a little more engaging. One of the other questions I get asked about chapter 5 a lot is what is the difference between Alzheimer's and dementia? Now, this isn't something that you need to know for the test. Nobody's going to ask you what is the difference between, but I find it's helpful for you to understand this. Dementia is a very non-specific term. Dementia just means brain sick. If I told you, hey, I'm not feeling well today, I'm really sick, that tells you I'm not feeling well, but it doesn't really tell you how I'm not feeling well. Am I not feeling well because I've got a head cold? I've got a sore throat? I have an upset tummy? My muscles ache? I mean, what sick doesn't, it could describe a lot of different things, right? But that term just means not well. Doesn't tell you how I'm not well, it just means not well. Well, dementia is brain sick. It just means brain's not working, but we don't know really how. It's a very non-specific term. There's many different things that cause dementia. They cause the brain to get sick. Things like Alzheimer's, which is basically a breakdown of the pathways between your cells, and it breaks them down and makes it a goo. So you have, all of your memories are made up of a lot of different things. For instance, in this room, you will have a memory of your CNA class. And you probably will associate it with black t-shirts because that's what you wear. You might see that color purple and it reminds you because you're sitting at that table and you see that banner all the time. It might remind you of this class. The smell of coffee, because we made coffee, will go into this memory. Memories are made up of sight, smell, sound, feel, and sometimes taste will go into what creates a memory. So all of these things are stored in different areas. And when you try to recall a memory, you have to kind of pull little things from all of the, because that color purple is not just in this room. That color purple may be on an Easter basket that you see at Walmart next week, right? So those little bits of information are going to be used in multiple memories. In order to recall a memory, you got to go pull all of these little things and shove them together to make the memory. Well, if all those connections are goo, all that might be left is purple. Because you can't get to the coffee. You can't get to the black t-shirt. Make sense? That's what Alzheimer's does. It destroys the connections. And this is why with Alzheimer's, sometimes, in some cases, you can have somebody that just has one word left. We cared for a woman in a long-term care setting, and her last word was apple. That's all she ever said, apple. Apple. Now, we drove ourselves nuts trying to figure out what apple meant. We gave her apples, applesauce, apple pie, apple drawings. I mean, but apple was the last word she had. Now, apple could have been red. It could have meant a feeling of safety and security because she went apple picking when she was 6. I don't know. I have no idea what she is referring to with that word. So when you're working with Alzheimer's, we have to understand that sometimes the word isn't referring to what you think it's referring to. It may be referring to a feeling, a color, a sight, a smell. And you got to get really good at decoding. Does that make sense? 6 was on skills. We've covered skills in class. So let me go ahead and get your scores for chapter 5 and 6. Just tell me how many you got wrong on each one. Dina? Ashley?
18 out of 20 for 5, and for chapter 6, 19 out of 20.
Thank you. Abby?
20 out of 20 for 5, and then 18 out of 20 for 6.
Thank you. Caitlin? Carsey?
20 out of 20 for 5, and 19 out of 20.
Thank you. Pilar?
18 out of 20, 19 out of 20.
Thank you. Michelle?
5, 20 out of 20, 6, 19 out of 20.
Thank you. Lisa?
5, 19 out of 20, 6, 20 out of 20.
Okay. All right. Okay. Any questions on anything that you went over?
I just mixed up one day and eloping, and I figured it out.
Okay, so yeah, so the best way to remember this is eloping. When you elope, like to get married, right? You leave everybody behind, and you go sneak off and get married, right? Eloping out of a facility, same thing. We leave everybody behind and we sneak off. So eloping is an unmonitored leaving of a facility or a unit. Wandering is simply wandering, going into places without a real plan, just wandering. A lot of dementia patients wander, a lot. And a lot of that has to do with that constant searching of the brain. You know, they've lost those connections. So wandering is very, very common. Activity with dementia is very, very common, just meaningless activity. Because when your body is in motion, sometimes it can quiet the mind. But eloping is a little more serious because now this person is not being monitored. We just had a situation where a nurse, a director of nurses, was charged criminally because a patient in a locked unit went outside. Nobody, during the winter, nobody was aware that she was outside. Nobody checked on her, and she ended up freezing to death, and she died. So eloping is a very, very serious situation because if we have a patient that cannot monitor their own needs for safety, if they can't keep themselves safe, that's the whole reason we're there, is to keep them safe. So a lot of times in dementia units, you will have what we call Q15 checks, which every 15 minutes you have to eyeball your patients to see where they are. And that's an important, don't skip that. Don't think it's just busy work. That's a very important task for direct caregivers because we're making sure that all of these people that are in our care are in fact safe. That's the main reason that we're there.
Don't these doors have alarms on them?
They do. Locked units, the doors are alarmed, but it's very easy for the door to just not close completely and somebody to slip out, or a family member comes in and holds the door helpfully for somebody that looks like they're trying to leave. A lot of times in locked units, we put things on the door to make it look less like a door. Like we'll put a great big piece of wallpaper that makes it look like a bookshelf. Things that make exits a little harder to identify. But yeah, it happens. How do I put this? In some cases, staff members, when they're going on break, will often prop the door open with a rock or a piece of tape on the door, the little thing that sticks out to latch the door. They'll tape that over so that they can get back into the building easier without having to interrupt another staff member. That should never be done, because if you prop the door open, that means that is an egress opportunity, a way for somebody to get out unmonitored. So that's way more common than you would think. We have to stop and think, why is this unit locked? It's for safety. So part of that's going to be our responsibility. Make sense?
Yeah.
All right. Oh, so class is half over, guys. You are now on the downward slide. 3 classes left after today. That's it. 3 classes after today. I have a game show tomorrow. That game show, I haven't written the questions for it yet. I'll do that this afternoon. So I'm not entirely sure what topic I'm going to focus on, but I might focus on dementia. That might be a good topic for tomorrow. So if you're interested in tuning in, it'll be at 11 a.m. Go to our YouTube channel. This is one that I don't put on our website. You have to go directly to YouTube. And because it's interactive, I have a program that sits on top of YouTube, and it will read your answers as they come in. And you have the opportunity to compete for prizes, real prizes. So let's do a quick review on what we've learned so far since the class is half over. How do we know what to do with each patient? Care plan. We follow the care plan, the whole care plan, and
Nothing but the care plan.
that means we don't change it. While we're following that care plan, half of our job is to make
Observations.
and then who do we report those
The
observations?
nurse.
Yep. Every skill starts with the opening. Every opening starts with a
No.
knock. We're going to greet the resident by name. And we're going to introduce ourselves by name and title.
Miss Patty, there's a question for you.
Helen says, my question is, if the nurse asks you to perform a task that's in your job description, but you have not done it before, what is your response? Great question, Helen. This goes into our scope of practice. When we are asked to do a task, the first thing we have to consider is, have I been trained to do this task? So if it's in your job description, you can go ahead and take that down, Jake.
Thank you.
If it's in the job description, chances are you have been trained. But if you're not comfortable doing it, if you've been trained but you've never done it yourself, then you can let the nurse know, hey, yeah, I was trained on that, but I've not actually done it myself. The nurse will generally watch you do it and make sure that you're doing it properly. Because remember, this is on their liability. So it's our responsibility to let them know, hey, yeah, I haven't done that yet. Where this comes up probably more often than anything else is postmortem care. Because not too many people have ever done postmortem care. And it's just bathing. That's all we're doing here is bathing the body. And one of the skills that we're going to learn how to do is bathing a body, right? So you're going to know how, but that doesn't mean you've ever done it. So you would just let the nurse know, hey, yeah, I haven't done that before. And they will, go help you do it or assign another CNA and have you watch and shadow on it.
Is that typical?
So, sure, absolutely. In some settings, not all settings. If you're working in the mother baby unit, you will never, ever, ever, ever do postmortem care. Not going to happen. If you're working in home care, you are not going to do postmortem care. If you're working for hospice, you're going to do postmortem care. If you're working in the ICU, yeah, you'll do postmortem care. So it depends on the setting. Does that make sense? I was a nurse for 10 years before I ever did postmortem care. Never had an opportunity. It just wasn't in the settings I was in. So I've been a nurse for 10 years. And the first postmortem care I did was not as part of my job. It was my grandfather. Postmortem care is a very reverent task. And you have to have a certain amount of gravity when you do this. You are the last person that will be providing personal care to this individual. There has to be a bit of gravity with that. And we want to make sure that we are treating the patient with respect, care, and concern. But this is also for the family as well, because if you are doing postmortem care, that means that generally family will be coming to say goodbye. We want the patient to look the best that they can. Does that make sense? So this has to be done with the right amount of gravitas. I don't just want to throw a brand new CNA, hey, go do postmortem care. I don't care if you've never done it before, just bathe the body, I don't care. That is not the attitude that we want to go into this with. Make sense? It's not nearly as scary as people think it is. It is no different than bathing a live body. It is literally, Hollywood has twisted your minds in a million different ways. Patients do not become super stiff until 24 hours after death. If it took you 24 hours to get around to postmortem care, there's a big problem there. So this patient is going to, their body is going to feel as if they were alive. Dead patients do not just suddenly sit up. That does not happen. Period. It's no different than bathing a live body. That there is absolutely no difference other than they're not breathing. That's it. That is the only difference. So it's not nearly as scary as a lot of people think it is. I think that the horror movie industry has really done healthcare a disservice here because it's made people afraid of death. Used to be, not even 100 years ago, people did not die in medical facilities. They went home to die. People died at home, and it was their families that cleaned them up. Who better to send you off than somebody that loves you? I think that we've lost a little bit of our humanity around death by making this a clinical thing. Death isn't as big a part of life as birth. No one gets out of this without dying. Nobody gets into it without birth. So the fear around death, I think, is a little unfounded. Postmortem care, you're just cleaning. But do it well. Do it well. All right, so we introduce ourselves by name and title. We describe the skill. We obtain permission. We close curtain, wash our hands, and get our supplies. But our big rule here is don't touch patient until your hands are clean. We have to evaluate if we're going to use gloves for every single skill, every single one. If there's a possibility that we might touch body fluids, personal skin, or non-intact skin, we need
Yes,
gloves. If we decide to wear them, what's the first thing they should touch?
the patient.
The patient. And then once you've got that patient's cooties on those gloves, you got to be careful about what you're touching in the environment so we're not cross-contaminating. And then we have to know how to remove those gloves correctly so we don't cross-contaminate ourselves. If we use supplies, we need a barrier. Barrier gives us a clean place to put our clean supplies. And we're going to go get that barrier first and then go get the supplies. That way we're not holding supplies up against our uniform. Remember, you have to have clean hands to get your clean supplies. Sometimes those supplies will include a privacy blanket. This is going to be used anytime the patient is uncovered or undressed, but we don't snap or shake this blanket when we put it on. We unfold it, put it over the sheet, and pull the sheet down underneath. At the end of the skill, when we go to take it off, we remove our gloves before we remove the privacy blanket. Good? Linen rolls. Linens can't touch our uniform. We've heard that before. You have to have clean hands to get your linens. That's a repeat. And we don't shake or snap linens. We already know that. We also know that anything unused must be discarded. We learned those. The last class, we added in the other two. Clean rolls toward me, dirty rolls away, and nothing touches the floor. Not clean or dirty. Nothing touches the floor. We also learned scoot and roll. Patients must always be in the middle of the bed. And we don't always have side rails to keep them there. If we are going to use side rails, what do we need? Doctor's order. So in order to keep the patient in the middle of the bed, we have them scoot toward us so that after we turn them, they're in the middle of the bed. We always turn them away from us. We remain behind, the patient's behind. Our cardinal rule here is patient must always be in the middle of the bed. Washing rolls. Basins are no soap zones because we have to have water for rinsing. We use a paper towel to get water and we check it. It should feel warm, not hot, not cold, just warm when we feel it with the inside of our wrist. But it's not enough for just us to check it. Who else has to check it?
The patient.
The patient, that's right. Whatever we wash, we rinse. Whatever we rinse, we dry. We're going to change that water if it gets cold or soapy. And we want to try to keep our surfaces dry. So no drippy wet washcloths that might drip on the floor or the table or the sheets. If we're going to use lotion, we warm it up first and then wipe off the excess. There's another principle we're going to learn today on washing rolls. Basin cleaning. We clean all basins the same way. Rinse it, dry it, store it. That's it. That's it. Just rinse it, dry it, store it for the test. But this process does allow for that disinfection step if you should need to do that. Set it down in the sink before you disinfect it. Then use a paper towel to pick it up, paper towel to dry the inside, paper towel to dry the outside, and one more for the door. And then we learn the closing. We want the patient to be in a clean environment. So take a minute to look around, make sure everything is nice and neat and clean. Make sure the bed is in the lowest position. You have to ask about comfort. They need to hear that word. Are you comfortable? And in addition to asking, we're also going to offer something for emotional comfort as well. Magazine, crossword puzzle book, TV remote, just something. Patient always has to be covered. We do not want to see knobby knees. So if they're not dressed, make sure they have a sheet on them. We'll adjust the head of the bed if necessary. We're going to open the privacy curtain, give the patient their call light, and it doesn't matter how you do all of those things. Do them all. Once you've done all that, you'll go wash your hands. We got to get this patient's cooties off of our hands. Once we have clean hands, we can document if required. But at the end of the skill, we have to wash our hands again. That's the very last action we take. So if you document, you wash your hands again after documentation. We learned how to take a pulse. A pulse is the measurement of how many times the heart beats over 1 minute. I'm going to time out here real quick. I want you to take a look at this back wall. We are halfway through the class, and you now know 95% of what's on that back wall. Remember I told you on the first day you were going to have to learn all that? And it looked a little overwhelming? Well, you've done it. You've done it. And it really wasn't that hard. Now, if you look on the back of your t-shirts, so if you stand up, let me have you stand up. If you look on the back of her t-shirt, in the For Your at the top are every one of those principles. And the CNA at the bottom are testing tips. So the shirt that you're wearing is a cheat sheet for the test. I probably wouldn't wear it to the test. I probably wouldn't wear it to the test or wear a jacket over it. Okay, so we now know the principles. Let's put them together with skills. So a pulse is a measurement of how many times a heart beat over 1 minute. It's always reported over a minute, but how long we count depends on that care plan. We're going to support the arm. Normal is between 60 and 100. We use our fingertips, not the flat areas. And we never ever use our thumb because your thumb has its own pulse. Radial pulse is at the top of the wrist near the thumb, just like right underneath that thumb where the lines are. We say start and stop for timing. So the evaluators start and stop counting when we do. And in Florida, you're going to count with 2 evaluators. This is a documentation skill, so you have to write it down. One of the comments, I was doing comments yesterday, and one of the comments I got on this video is somebody said, you didn't announce your reading. You don't announce your reading. The care plan says to measure and record. If you stand up and say, I got 72, what'd you get? That evaluator is not going to answer you. They don't even exist. They will not answer you. They will pretend like you never spoke to them. And that can get really unnerving for people who expect an answer. Our care plan says measure and record. So that means we have to document. Make sense? Good? All right. We learned how to dress a resident. We're going to ask what they want to wear. We're going to get that clothing before we undress them. That minimizes exposure. We're going to lift from below, supporting all joints. We'll undress the strong arm first. This is the main thing that they're testing you on. Undress your strong arm first and dress the weak arm first. That way that weaker arm doesn't have to do a lot of movement. You want to adjust the clothing for neatness and appearance. Make sure they look nice and neat because you are judged by how your patients look. Put all the soiled items in the hamper and put the call light in the stronger hand. Hand and nail care. This is easy. It's a mini mani. You soak a hand, you take it out to wash it. You put it back into rinse, you take it out to dry it. Clean under the nails with the slanted end of the orange stick and file the nails in one direction. You want to make sure the hand is on a towel as you're doing this and support that arm and wrist as you're moving it. Apply lotion last. Anytime we put lotion on, we warm it up first and then wipe off the excess. We learned how to make an occupied bed. We're going to change the bottom sheet a half at a time, making sure the patient remains in the middle of the bed. So to do this, we're going to get the patient laying on their side in the middle of the bed, so taking up less space. Clean rolls toward me, dirty rolls away. We'll change that bottom sheet. We'll go to the other side of the bed, finish changing the bottom sheet, and then put the top sheet on top. You've got to get the corners under the mattress. Hospital corners are best, but get the corners under the mattress, because nothing should touch the floor. Remember, clean, dirty, don't touch the floor. And then we'll change that pillowcase with the opening facing away from the door. Remember, you don't want your patient exposed, so use privacy blanket for this. You don't want that. I can see knobby knees. Should I ever see knobby knees?
No.
I had a student not too long ago that came back to tell me, this is before we left the old place. She says, I know that you said that I hear your voice in my head. She says, but the one thing I kept hearing is knobby knees. She says, that's the one thing I kept hearing from you is no knobby knees. She said, so I did good on the test. Nobody saw the knees. It does work. Side lying position. We're going to turn our patient on their side, but this time the patient can't really help, so we've got to position them properly first. The furthest arm goes up, the closest arm crosses over. Closest knee is bent, furthest knee is angled. And then we just roll them onto their side. But if I don't scoot them toward me first, and I do this and roll them on their side, where would they be? Yeah, on the edge of the bed. That's not safe for anybody. So we scoot them first, arm up, arm over, leg bent, leg angled, and then roll them. Put a pillow behind the back to keep them from rolling back. Put one between the legs, specifically between the knees and ankles. You want one under that upper arm to get it in a nice neutral position, and adjust the one under the head. Call light goes in the lower hand. Foot care, just like hand and nail care, a little lower. We don't do anything with toenails. So we're going to support the foot while we move it into the basin and out. And it always needs to be on a towel when outside of the basin. So we put the foot in the basin to soak, take it out to wash, put it back into rinse, take it out to dry. You want to look at the foot. This one's all about inspecting. We're going to, when we dry, blot in between the toes. And we'll put lotion everywhere except between the toes. Wipe that lotion off and then put their sock and shoe back on. Can you adjust the air? Maybe it's a little bit cooler. So mouth care. How do you brush teeth? Don't overthink this, guys. Just make sure they're sitting up. You got to be in an upright position. You want to protect their clothing. You're going to wet that toothbrush before you apply toothpaste. And you brush all surfaces of the teeth and gums as well as the tongue. You're going to let the patient rinse and spit as much as they need to. And we're going to leave their mouth dry at the end. Remember, I said that is the one step that is most missed. Don't forget to look at your patient. Remember, it's always about the patient. We learned how to count respirations. We don't want the patient to know we're counting their breathing because it will alter their breathing. So we say vital signs. You can use an alcohol pad for this. There's no problem with that. Respirations, like pulse, is always reported over 1 minute. It's reported over 1 minute. Normal's between 12 and 20. We don't tell the patient that we're counting their respirations. We're going to say start when we start counting, stop when we stop counting. There's a clock above the bed, just like here. That's what we'll use for timing. In and out's counted as one full cycle, and this is a documentation skill. We've learned range of motion, 2 of them so far. We're going to lift extremities from below with a flat palm, 2 points of support near the joints. We'll move slowly and smoothly all the way to start. Flexion extension is up, down. Abduction, adduction is side to side. Rotation is around. Follow the care plan. Whew, look how much you've learned. That's a lot. You guys have learned a lot. And I still have 2 more weeks with you. The good news is it gets a little easier from here because we're just gonna recycle what we've learned so far and put it into some different skills. So let's learn range of motion of the hip knee, and ankle. Sorry,
Oh, you're fine.
getting to play limbo on a Monday morning.
Gotta wake up somehow.
All right, so this is on page 80. Nothing new to learn here. Nothing new. You can see all the principles going down the side. They're all spelled out here for us. We're going to follow skill rules, the opening, glove rules, range of motion, and the closing. Remember, glove rules is evaluated with every single skill because we don't know. It's always based on the patient, not the skill. I have a video for you, and down here is test-specific information. Somebody with your level of experience should be able to do this in 4 minutes or less. This is going to be done on a live testing person, and they will be in bed. Documentation is not required. Thanks. There's nothing new to learn here. Let's take a look at this care plan. Care plan tells us to provide the following range of motion exercise to the resident's right hip, knee, and ankle. Should we do the left too while we're there? No. So it tells us to do flexion extension. That's it. Flexion, that's it. So remember, flexion extension was up, down. Tells us to provide 3 repetitions, and the resident is not able to help. So let me explain to you why this is one is just a little bit different. The hip and knee is a 2-for-1 exercise. It's a 2-for-1. When you bend the knee, when you bend the hip, you have to bend the knee too. You don't want that knee to be straight. And I'm going to show you why in just a minute. So when we bend the hip, we also bend the knee. Both of these are going to be exercised with the same exercise. Now, why don't we want to just go straight up in the air? Down the back of your legs, you have nerves. They actually come off of your spinal cord and split into 2, and they run down the back of your legs. Now, these are already pretty tight. So think of it like a rubber band. There's some flexibility there, but not a lot. And we already have that rubber band stretched. When we do this, when we keep that knee straight and we bend that hip, that stretches that rubber band past its point of resiliency. And that can cause pain down the back of the patient's legs. This is often called sciatica. Now, when we aggravate that nerve, this right here, when we aggravate that nerve by pulling it too tight, it can take weeks, months, or even years for that nerve to recover. That means this patient's probably not sleeping well for the next couple of weeks, months, or years because they can't get comfortable. So a very important part of this skill is making sure that we're bending the knee as well as the hip. When you do that, when you bend the knee as well as the hip, I'll show you here. When you bend the knee like your patient is walking up steps, you bend the knee and the hip at the same time, it provides some slack in that nerve. So flexion extension of the hip and knee is done at the same time. Then we go down to the ankle and we bend the foot forward and back for flexion extension of the ankle. Now with the ankle, you don't want that heel to scrape against the sheets because the heel, there's an area of pressure there and it can cause a sore or abrasion. So when we work on the foot, we put our hand below the lower leg to get that heel off of the bed. Not a lot. You just want to elevate that heel off of the surface of the bed a little bit. Good? So our care plan says we're going to bend the knee to the chest 3 times. Monitor for pain. Elevate the foot. Bend the foot back and forth 3 times. Monitor for pain. Put an opening in front and a closing behind. That's the whole skill. You have 4 minutes to get that done. Doesn't take 4 minutes. Jake, you want to put the video on?
Range of motion.
Hip, knee, and ankle.
Mm-hmm.
Hello.
Hi, Mr. Jones. My name is Patty. I'm your CNA today. How are you?
Doing great. How about you?
Wonderful. I need to do some exercises on your right hip, knee, and ankle. Is that okay?
Yes.
I'm going to close your curtain. Let me go wash my hands, and I'll be right back.
Okay.
Okay, I'm going to do all the work. All you have to do is let me know if there's any pain or discomfort as we do this, okay?
Okay.
The first exercise is going to bend your knee up to your chest and back down to the bed like you're climbing stairs.
Okay.
We'll do this 3 times.
Okay.
Please let me know if there's any pain.
All right.
I'm going to support under the knee and under the ankle, and we're going to lift and bend all the way up and all the way back down. Feel okay?
Yes.
We're going to do this again, all the way up and all the way back down. Still okay?
Yes.
One more. All the way up and all the way back down. Next exercise we're going to do will be on your ankle. I'm going to lift your foot off the bed, and we're going to bend forward and backward like you're stepping on a gas pedal.
Okay.
We'll do this 3 times.
Okay.
So I'm going to lift, and we'll bend forward and backward 1, forward and backward 2. Feel okay?
Yes.
And one more. Okay, any pain or discomfort?
No.
Is there anything else I can get for you while I'm here?
No.
Magazine perhaps?
No, thank you.
Okay, let me get your call light for you, and I'm going to open the curtain.
All right, thank you.
Here's your call light. If you should need anything at all, please let me know.
Thank you.
I'm going to go wash my hands. After washing my hands, I'll review the steps of my skill, make any corrections, and tell the evaluator my skill is done.
Okay. Oops, yep. Sorry. Okay, can you get the light?
Sorry. Lights coming on?
All right, let's send a, oh, no, that's not it. I hit the wrong one.
I'm not quite sure how to help you with that.
Stop. All right, let's send a congratulations out to QA. Passed my exam this past week thanks to you and your videos. I appreciate everything you're doing. Thank you. So congratulations to you. Great job. We're super proud. All right. Oh, we've already done all this. Let me skip through here. All right. So, do you guys, am I unmuted?
You were muted during that.
Yeah, congratulations, QA. I'm sorry I was muted. Congratulations. Great job. Okay, so do you guys remember mouth care? Do you guys remember mouth care? Denture care is mouth care with an extra step. But with mouth care, the patient was laying in bed, and we had to get the head of the bed sitting up. For this one, the patient will be sitting in a chair at the side of the bed. So they're already sitting up. They make it a little bit easier. We're going to brush the dentures and the mouth those dentures came out of. Mouth care is actually an important part of denture care. And that's because dentures are usually held in with denture paste, which is going to trap food particles right up next to the gums. As those food particles decay, they can eat into the gum tissue. So when we have a patient that has dentures, yes, cleaning the dentures is important, absolutely. But we have to remember to clean the mouth those dentures came out of as well, because that's going to help prevent illness and injury inside the mouth. Good? Make sense? All right, so these are all of the principles that are involved in this skill. They're all spelled out for you here. We have a video for this, and down here tells you information about the test. Somebody with your level of experience, which is none, should be able to do this in 13 minutes or less. You're cleaning the dentures, and you're cleaning the mouth those dentures came out of. It's going to be done on a live testing student. Yeah, so now you guys are all panicking. Wait, hold up. I don't have dentures. How is this going to work? I'm going to explain it.
That person will be sitting in a chair, charting is not required. So let's get to how you're going to be a patient for this. Nothing new to learn. Let's read the care plan at the top, page 97. Care plan tells us a resident with dentures is sitting on an overbed table with their dentures in a denture cup. So, for the test, your patient would be sitting at a table and they will have a cup with dentures in front of them. Your job is to clean those dentures and clean the mouth those dentures came out of. You guys all have a mouth, so that works.
It's basically we just brush them.
And I'm going to explain why, because there's a missing part of this you guys probably aren't aware of. It says the resident's denture needs to be brushed with toothpaste and the resident needs mouth care. The denture is stored in a denture cup after cleaning. So, if we follow this care plan, are we taking dentures out of somebody's mouth?
No.
Are we putting dentures in somebody's mouth?
No,
And that's because of the care plan. Do you guys see how following the care plan is so important? Says the resident is not able to provide their own mouth or denture care. In a clinical setting, if the patient cannot take their own dentures out and they cannot put their own dentures in, they don't use dentures. We puree their food. We chop it up really fine so they don't have to chew. So you as a CNA do not put dentures in. You do not take dentures out. The patient has to be able to do that themselves. And there's a very good reason for this. If I have dentures, particularly on the bottom, okay, if I have dentures on the bottom, in order for me to get those dentures out of my own mouth, I have to put my fingers way back here where the denture's in and pop them up and out. Okay, do you see how my fingers are? In this position, I never put enough pressure on my jaw to dislocate it because of leverage. But if I put my fingers in your mouth, in order to pop those dentures up, these knuckles have to press down in order for those fingertips to pop up. There has to be counter leverage. You are pressing down on the bottom of somebody's jaw.
so you never put dentures in that.
Right. That risks dislocating the patient's jaw. So we don't take dentures out. Patient has to be able to do that. We also don't put dentures in. And for this reason, when you put dentures in somebody's mouth, they are automatically going to bite down to seat those dentures. It's a reflex. You can't stop it. You will bite down to get those dentures in the right place. Well, if your fingers are in the mouth, what's going to happen? And they don't mean to. It's a reflex action. So you are at risk of being bitten. And because they're dentures and they're not seated properly, they have no idea how much pressure they're exerting. So we don't put dentures in. We don't take dentures out. Not our job. The patient has to be able to do that themselves. Good? Does that make sense? So for this skill, it's already been done. The dentures are in a denture cup on the table. We're going to clean the dentures, put them back in a clean denture cup for the patient to use whenever they wish. And then we'll brush the mouth those dentures came out of. Good? Make sense? All right, so there's a couple different types of dentures. Dentures have to be stored in water. We're going to get to that in just a minute. Mine are not. They're not. But dentures have to be stored in water. Otherwise, they become very brittle and they're likely to break. There's a couple different types of dentures. When we talk about dentures, we generally think about this, a full plate. This is what we think about when somebody says dentures. All of the teeth have been replaced. These are what people call false teeth. But it replaces all of them. This is a top plate because it's got a palate. This goes against the roof of the mouth. But if the patient has
some healthy teeth. We generally don't pull out healthy teeth. We will pull out the unhealthy teeth and leave the healthy ones and create a denture that will go around the teeth that remain. This is called a partial. So just because somebody has dentures, a partial, doesn't mean they don't have teeth. Got it? So when we are cleaning the dentures, they could be a full plate. They could also be a partial. And we're going to clean whatever's inside the mouth. It might just be gums if they have a full plate, but it also might be teeth if they have a partial. Good? Make sense? And then we have something called a bridge. Now, bridges are a little less common than they used to be in years past. Bridges are when we artificially replace a few teeth, one or two. And bridges generally clip around teeth that are beside it. So this is generally just to replace a few teeth. Now, current day, most bridges are implants. So they don't come out. They're just, we're replacing a few teeth permanently on posts. Good? Make sense? So you won't see as many bridges as you used to, but we are dealing with an older population. So this person may have had this bridge for years and they still have it, because putting an implant in at age 85 doesn't really make a lot of sense. Good? Except to the dentist. It definitely makes sense to the dentist. All right, so there's lots of different types of dentures. Questions? So we need 2 sets of gloves for this skill, and this is the part that messes every student up. When do I change my gloves? The answer is nobody cares. This is not a graded checkpoint. Does not matter. Got it? Not a graded checkpoint, but I'm going to tell you why we're going to do it in a certain way. If I were to brush your teeth, do you want me to have clean gloves or gloves that have touched everything before I brush your teeth? You want clean gloves, don't you? Mm-hmm. So remember, we're going to clean the dentures and then we're going to clean the mouth. So if we put gloves on and go over and clean the dentures, by the time we get over to do mouth care, our gloves are, contaminated, dirty, absolutely. Nobody wants dirty gloves in their mouth. So we want to put a clean pair on before we do mouth care. Good? Make sense? So we're going to have one set to brush the dentures. We're going to have one set to brush the mouth. Where you change in between is not graded. But we have a rule that should tell us, you already know this answer, by the way. We have a rule that should tell us when we should change our gloves. What is the first thing our gloves should touch? The patient. That's right. So that should tell you when you change your gloves. The first things our gloves should touch is the patient. Good? Make sense? Isn't it fun when you realize you already have the answer to the question?
Are you having to wash your hands in between?
No. Now you can. For the test, you can wash your hands as many times as you want to. There's no limit on how many times you can wash your hands.
Graded between.
Yeah, it's not graded. And the reason for that is it's the patient's cooties. Remember, the patient's very familiar with their own cooties. We're not really worried about the patient's cooties. We're worried about bringing the patient other people's cooties. So because we're taking one set of gloves off that were used for that patient's things in that patient's environment, we're just going to put a second pair of gloves on before we clean the patient's mouth. If you want to wash your hands in between, go for it. Nobody cares. But it's not required because it's just that patient's cooties. Good? Make sense? Okay. Some students ask me, can I do mouth care before I clean the dentures? And the answer is yes, absolutely. If you want to do mouth care first and then denture care, that's fine. If you want to do denture care, clean the dentures and then do mouth care, that's fine. Nobody cares. But I am going to tell you that it does give you an extra step if you clean the mouth first. And that's because that patient's going to have to spit into that basin with mouth care. That means you got to go clean the basin. That's fine. You can do that. But we need that basin to hold our denture brush at the sink. So at the end of the skill, you would have to clean the basin again. So if you do mouth care first, you have to clean the basin twice. If you do the dentures first, all that basin has held is the toothbrush. They can spit in it because we're going to clean it after mouth care. And I know it's a little complex, so I'm going to tell you, you can do it either way. But if you do mouth care first, please remember you have to wash your basin twice. I'm all about efficiency. So the way you're going to see me do this is I do denture care and then mouth care. Okay. So there's two ways to clean dentures. There's toothbrush and toothpaste, which, I mean, if you could take your own teeth out and brush them, that's what you would do, right? It'd be a whole lot easier than doing it in your mouth because you can see. You can get all those little nooks and crannies. So toothpaste and toothbrush, same way you brush teeth. The other way of cleaning dentures is using fizzy tablets. Now, I'm going to tell you that most dentists prefer this method because toothpaste is abrasive on purpose. It's abrasive. Well, dentures aren't made out of bone. They're not like living. They're not able to regenerate those little micro cracks that form with toothpaste. So when you brush dentures with toothpaste, you're actually creating little tiny cracks with the abrasiveness of the toothpaste. And that's not really good for dentures long term. But our care plan tells us to brush the dentures with toothpaste. So that's what we're going to do because our care plan told us that's what we're going to do. In most clinical settings, the patient's going to want you to use these little fizzy tablets. You put the dentures in cold water with fizzy tablets, and those tablets actually break down the protein particles, and you just rinse the dentures off in the morning. Maybe a soft brush, but most of the stuff is gone because that's the job of these fizzy tablets. So we always follow our care plan to tell us in a clinical setting which way we're going to clean dentures. Fizzy tablets are way easier too, by the way. When we're working with dentures, there's a special brush we're going to use to clean the dentures themselves. It's called a denture brush. Looks like this. It's a double-sided toothbrush. One side looks like a toothbrush. That's going to clean the teeth part of the dentures. The other side is narrower. This is going to clean the channel part of the dentures, the part that goes over the gums because it fits in that channel very nicely. Good. So this cleans the channel. This part cleans the teeth. So double-sided. To clean the mouth, you can use a regular toothbrush, but the problem is that denture paste that holds in those dentures gets all gummy and stringy, and it's going to get all wound up in these bristles, and it's not going to be overly effective. So in the mouth, we use something different than a toothbrush. We use this. This is called a toothette or an oral swab. It's soft, spongy, but more importantly, it's solid surface. It's got little cells in it like a sponge that are going to collect all of that paste. but it's still a solid surface so we can swipe that paste away. This is preferred when we're doing gum care for dentures. The other nice thing about this is you can use this side. Once it gets all gummy, you turn it. Then you use this side. Once that gets all gummy, you turn it. Now we've got another side and we can turn it. We got another side. And if you think of your mouth, there's 4 quadrants. 1, 2, 3, 4. So that makes this very effective for cleaning that denture paste and food particles off of the patient's gums.
Is that the same thing that you use for lips? Like with the patient?
Yes, we use it to moisten lips. There's also something that looks like a giant Q-tip. It's a giant Q-tip. And it's, they're called lemon glycerin swabs. They use that as well to help moisten because the glycerin really penetrates and keeps moisture in the area a little bit longer. If you use a swab, we just dip it in water and that tends to evaporate pretty quickly, especially if your patient's breathing through the mouth. So the lemon glycerin swabs are usually preferred if there's a moisture issue. But yes, we do use that. All right. Okay, so once we get started on this skill, we've done our opening, gotten our supplies, all that. We're going to wet the toothbrush, or the denture brush in this case. We're going to apply toothpaste to both sides. And then we have to take it to the sink, but I don't want it to lay on the surface of the sink. So we're going to put that denture brush with the toothpaste on it in our emesis basin. And then we're going to take it to the sink. You don't want to lay it on the side of the sink. We have to have somewhere for it to stay until we're ready to use it. We're not ready yet. We got some stuff to do. So that's what that basin is going to do. It's just going to hold that denture brush until we're ready to use it. The reason that we need that is because we need 2 hands here. I'm going to be working with a denture that has denture paste on it, and then I'm going to put toothpaste on it and have it under running water. This thing's about to get all kinds of slippery. And chances are I'm probably going to drop it at some point during this skill. I'm going to try really hard not to. But if I do drop it, I need something soft at the bottom of the sink that's going to keep it from breaking. So I'm going to put a washcloth in the bottom of the sink. Paper towels don't work as effectively. If you're going to use paper towels, you need to use several of them to make a bit of a soft layer there. But for the test, we have washcloths. Let's use them. So we're going to put a washcloth under the running water. Now, bonus if you can get it over the drain, because that will kind of act a little bit as a stopper. It'll limit the water that's going out of the sink and the water will pool up. So if I have a pool of water and the dentures drop, they're going to hit the water, which is a soft surface, and then they just kind of gently go down to the bottom. So it helps prevent breaking of the dentures. So washcloth in the bottom of the sink. If you can get it over the drain, even better. Any questions? We're going to use cold water, not hot. There's a nursing principle that says heat coagulates proteins, which means nothing to you. What it means is that it makes proteins stickier and harder to remove. Now, denture paste, protein. Saliva, protein. Food particles, protein. We don't want to make those protein particles harder to remove. So cool water is best when we're working with dentures, not hot. We want to turn that faucet on with a paper towel. We've got gloves on. We don't want to touch those dentures with dirty gloves. So we're going to use a paper towel to turn the cold water on, not hot water. We will wear gloves while we're handling the denture. We can handle the denture cup without gloves, that's fine. But I don't want to open this thing and reach in and touch dentures with my bare hands. So you need gloves on to touch dentures. And the first thing your gloves should touch is the patient, in this case, the dentures. We're gonna brush everything. Top, bottom, front, back, groove, palate, all of it. For the test, you're only gonna have one denture, one. It will probably be a full plate, but you will have one denture to brush. We don't want to set the dentures down in the sink. They always have to be in your hand. Keep your hand over the sink, because like I said, you're likely to drop these things. If you've got them outside of the sink and they fall, they're going to break when they hit the floor. Dentures can only be held in your hand, the emesis basin, or the denture cup. That's the only place that dentures can go. Once we have those dentures clean, now we need a clean place to put them. So we're going to dump the water out of the cup. We're going to rinse the cup and fill it up with cool, clean water. We'll put the denture in the cool, clean water cup and put the lid back on. Now the patient has dentures that are clean for whenever they want to use them. The problem is this whole process, dumping the water out, rinsing the cup, filling it up with water, is going to make that cup wet. If I have a wet cup and I put it on furniture, what's going to happen to the surface of the furniture? It's going to get wet, and it probably will leave a ring. It'll warp the furniture. So when we clean that denture cup and we put the dentures in and we cover it, we want to put that denture cup on a paper towel before we put it on a surface. That paper towel is nothing more than a coaster. And we're going to put the denture cup on a paper towel on the bedside drawer for the patient to use whenever they want to. Good? Good? Once you do that, we're going to take the washcloth out of the sink, wring it out, put it in dirty linen. I don't want to touch that washcloth without gloves because it's got saliva and all kinds of stuff on it, right? So I need gloves for that. So I'm going to get that washcloth, wring it out, put it in dirty linen with my gloves on. I'm going to grab, where is it? I'm going to grab the denture brush in the basin and bring it over to the table. Again, I don't want to touch this without gloves because, ew, right? So once I have this emesis basin on my table, on the barrier, and I take the denture brush out and put it to the side because the patient's got to spit in here, then I'm going to take my gloves off. I'm done with denture care now. Now I'm ready for the mouth care portion. But before I put those new gloves on, I've got to think. The first thing my gloves should touch is the patient. So I need to do all of my prep work before I put my new gloves on. So I'm going to wet the toothette. I'm going to put some toothpaste on it. I'm going to put it in the basin just to hold it for a minute. And I'm going to put the towel on the patient. Now that I've got all my prep work done, then I can put my second set of gloves on. Good? And then I'm just going to brush whatever he's got. Top, bottom, front, back, tongue. Nobody's timing you. Nobody cares. Just brush all surfaces. Let them rinse. Let them spit. And then dry the face. That's denture care. So in here, in this classroom, you have not had any practice time yet. Starting on Wednesday, we might have a little practice time today, I'm not sure. But starting on Wednesday, you will have about 45 minutes of practice time. Next Monday, you're going to have about an hour of practice time. Wednesday, graduation day, you'll have about 2 hours of practice time. So in here, you have dentures to be able to practice with. They're right here on the bedside table. Those of you at home can't come in here and practice. So you need something to practice with, and chances are you don't have dentures just laying around. Our practice kits that we have everything you need to practice. So if you're not going to be practicing in here, I would suggest getting a practice kit. That practice kit has gait belts, which we're going to learn about today. It has all of the basins, wash basin, emesis basin, triangular graduate. It has a urine drainage bag, and it has dentures. These are denture simulators. They have a groove, just like dentures. They have the teeth, just like dentures. This allows you to practice doing denture care if you're not practicing them in here. Now, for you guys, while you're enrolled in class up through graduation day, the practice kits are $50. You guys online, the practice kit's $65, I think, on my website. So you guys get a little bit of a break on that. But if you practice in here, it's free. I've got everything you need to practice, right? This is more for the people that are doing it from home. Good? Questions? Questions? All right. Jake, can you put on denture care, please? And then I'll get the lights. And then we will take a break.
Hello.
Hi, Mr. Jones. My name is Patty. I'm your CNA today. How are you?
I'm doing good. How about yourself?
Wonderful. I need to do denture care on you. Is that okay?
Yes.
I'm going to take your dentures to the sink. I'm going to close the privacy curtain and wash my hands. I'll be right back.
Okay.
Okay, Mr. Jones. I'm going to place a barrier on the table so we have a clean area to place the clean supplies. And then I'll gather the supplies that I need. We'll need a cup of water, a toothette, a denture brush, toothpaste, a basin, a washcloth and a towel, and 2 sets of gloves. Okay, we're going to get the denture brush ready for use, so I'll wet it and apply a little bit of toothpaste to both sides. We'll allow the basin to hold that denture brush until we're ready to use it. I'll be right back, Mr. Jones. I'm going to go clean your dentures.
Okay.
Okay, Mr. Jones, I'm just gonna set your dentures over here so that you have them if you should need them later.
Okay.
I'll place the denture brush on the barrier and now we'll remove these gloves. And we'll throw those away. Do you mind if I place a towel over your chest?
That's fine.
This will help keep your clothing clean.
Thank you.
We're going to prepare for the mouth care portion of this skill. We'll take the toothette and wet it. Apply a little bit of toothpaste to one area of the toothette and apply gloves. Okay, Mr. Jones, I'm going to brush all surfaces of your teeth now. So in a moment, I'll need you to open your mouth wide so that I can reach the back teeth.
Okay.
Okay, can you open your mouth? Thank you. I'm going to brush the back on the bottom and on the top, both sides. Okay, can you bring your teeth together, please? Thank you very much. We're going to throw the toothette away. And would you like to rinse? Very good. Would you like another rinse?
Yes, please.
Another rinse?
No, thank you.
Okay. I'm going to remove your towel and we'll place this in dirty linen. We'll throw away the disposables. And now I'm going to clean your basin. I'll be right back.
Okay.
I'll place the denture brush and the toothpaste in the basin and open the drawer with a paper towel to store the basin and other supplies. I'll remove the barrier from the table and we'll throw this away as well. Now I can remove my gloves. Mr. Jones, are you comfortable?
Yes, ma'am.
Can I get you a magazine?
No, thank you.
Is there anything else that you need?
No, thank you.
Your call light's right there. If you should need anything, just let me know. I'm going to open your curtain and go wash my hands. After washing my hands, I'll think about the steps of my skill, make any corrections, and then tell the evaluator my skill is done.
Lights coming on?
All right. Any questions on denture care?
Do we wash our hands? After we took out the first aid gloves, after we did the dentist, before we do mask, do we wash our hands too?
You don't have to because it's the same patient, same foods.
Okay.
So you can if you want to, but you don't have to. Okay, good. This skill, for whatever reason, seems to be the hardest skill for students. Denture care. I know it doesn't look hard. I make it look very easy on the screen. I understand that. But this is one that you will kind of get tangled up in the middle. And that's why I want you to understand that that part, that transition isn't really graded. Okay. But there is, when you go from cleaning the dentures to cleaning the mouth, that part in the middle, that transition seems to really tangle students up quite a bit. They're not grading that harshly. All right, any questions? Let's go ahead and take our break. And then when we get back, we have 2 more skills to do. One of them takes a long time.
You are muted. Excuse me.
You can move your chair over if you want.
Oh, that's fine. I'll grab one in a second. Sorry, I was late this morning.
It's Monday.
Well, that doesn't excuse it. I had my alarm set, didn't hear a single one this morning. I'm laying there, I'm like, I shouldn't be awake right now before my alarm. So something's wrong. And I laid there for a minute, I'm like, no, I've got time. And so I'm like, no, it's too bright out there through my eyelids. So I roll over, I look at my clock, I'm like, oh.
So we are kicking around an idea.
Oh.
Let me show you. And right now we're just kicking.
Okay.
Okay.
Oh. I like that. That would solve a number of issues.
No, it's not for this.
I know.
That's
Station.
for you.
Yeah. Ship station.
That gives us a dedicated address.
Yep, that's where my mind is.
It gives you a schedule
Mm-hmm.
because I think that we're kind of floating right now with no clear
It gives me a little bit more consistency, but
Yes.
also it gives you guys the privacy.
right.
That I've already seen that there's a bit of a, not saying it negatively, but an impotence on your guys's impedance on your guys's ability.
Yeah, I know.
No, I get that.
I know.
I need more office hour flexibility, and it's just not possible with the situation.
Can you find me an Emory word, please?
I am 100% behind that.
So I've got a call out to them regarding this,
That would be awesome.
but there's another one that
I just need something for me to store and take deliveries.
right. That's the big thing is the deliveries. So this is the other one. Hold on.
Plus having a physical office at any time I can do what I need to do, and it's right up the road.
Well, this other one is even better for you.
I mean, that price can't be beat though. Comparatively, you know?
Yeah, I know.
Okay, so we're over there by Springstead.
This is,
Yeah, that's Mariner Commons.
it's on Lamson. Oh, here it is right here. So this one,
Oh, I see where that is. Okay.
this is,
That's in that commercial park area down there.
Yeah, kind of.
Yeah,
but
it's like the roofing company, the shed company.
This is actually, there's the tunnel. Where is, I'm on the wrong, there it is. Let's go. Let's remember right here. Okay. Had to get my bearings, sorry.
That should be the O'Reillys and the
It's
Dollar
this one right
General.
here. Yeah,
Yeah, I know where you're at.
right there.
Okay.
Same price. This would be closer to you
Yeah, that would be a lot closer.
because you could go right up.
And that's also a short jaunt to the post office.
Right. So this one I'm going to call about. I haven't called about this one.
Okay. No, that'd be awesome.
But if you can go up and take care of the dogs,
Oh, yeah.
I'm going to see if I can. I have to go to the flooring. I got to go to Cadence, but I'm going to call them and see if I can
Mm-hmm.
look today while I'm out.
Yeah, as long as if it's the size of the garage, at a minimum,
It's
I have enough space.
400.
Oh, it's way bigger. The
So-
garage is only like what, 150, 175 maybe?
You maybe 200, maybe. We would keep this here.
Oh yeah, of course. We still need a classroom.
Right. This isn't for the classroom. This
No, I
is
know. This
for-
is just for me to have my shipping. So we have an address, we have a shipping center, we have a
Mhm.
steady, verified location.
right.
And also confirmed, or it kind of simplifies a lot of our issues that we're having in the documentation, man.
Right.
So we can actually get that situated. No, that's a decent sized office unit. That'll be perfect for me.
So it's
400 square foot is, yeah. As long as I have enough space to organize all of the kit materials and then still
Mhm.
have a section where I can have the pre-assembled kits and everything similar to how my office is set up now. As long as I
Right.
have space for that, I can work with it. And
Mhm.
I can make it work beyond that.
that's something that we can do. I
Yeah.
mean, that's handleable.
Simple.
And I'm actually looking, the other one would be more convenient for me,
Mm-hmm.
but I'm actually leaning more toward this one, but I want to go look at it.
See, I like the idea of having one that is rather convenient for you because one, you need an office too. And it's not for the sake of I need an office to work out of. You need an office for in those eventualities that you're meeting with instructors.
Yeah, I know.
You need that corporate facing position beyond the camera.
I like the way the other one looks, presents.
Yeah.
Rather than
If
this
it's a
one.
public facing thing, that's a consideration.
Yeah,
But since this right now, the design is just going to be simply for personal shipping, anything you guys can work out, I'm cool with.
Yeah.
200 square foot is more than enough for what I'm doing because I can organize appropriately.
right. But I want you to be aware
Mm-hmm.
that some of this would probably be used for storage.
That's fine. And I was going to offer
Yeah.
that too. Like, I'm not going to be using the whole thing. We'll work on that because also we need to get some of that stuff out of there. So Dad has his position.
Right.
He needs his workspace, especially now considering he's picking up more jobs in either the land clearing or the curbing work, which that's gonna be fun doing more. Stepping gum outside.
Hmm?
Stepping gum outside on the sidewalk.
Mm.
Drives me crazy.
Every
People
time.
put the gum on the ground.
Right on the sidewalk too. Make it a copy. Do you need anything?
Mm-mm.
Oh, just wait.
Sorry.
No, you're fine.
Okay.
Unmuted in 3, 2, 1. The mic was hot the entire time. You were muted, but it wasn't muted.
Wow. Okay. We're going to talk about energy conservation. And this is a topic that's hard to understand because you've never really lived it. Anybody ever see a 2-year-old? I love 2-year-olds. They're my favorite age. Hands down, my favorite age. Love 2-year-olds. Curious about everything. But 2-year-olds will jump up and down for no reason. No reason. They have energy like crazy. Have you ever tried to explain to a 2-year-old why you do not have the energy level they do? They don't get it. They don't get it. They're like, come play with me. Oh no, I can't. I'm too tired. Come play with me. They don't get it because they've never lived it. They've never experienced it. All they have is their own experience to draw from, right? That's going to be important here. So what I'm talking to you about is the lecture is going to be on page 63. And 2-year-olds have energy levels that are off the charts. They will jump up and down for no reason. Think about when the last time you jumped up and down for no reason is. Probably when you were 2. But we don't stay at that energy level. The energy level declines from that. In fact, your maximum amount of energy that you'll have in your lifetime is right around 2. It's downhill from there. And I'll prove it to you. 12-year-olds, still tons of energy. They can skateboard, play basketball, play video games. Tons and tons of energy. But you put that 12-year-old in charge of that 2-year-old for one afternoon, who wins? 2-year-old, absolutely. 12-year-old's like, Mom, can't they take a nap or something? Right? Energy levels have declined. It doesn't seem like it to you, but energy levels decline because that 12-year-old cannot keep up with that 2-year-old all day. Let's go out to 22. 22-year-olds will shop till they drop and still go out at night looking fabulous. Okay, still lots of energy. But that 22-year-old does not have the energy level they had when they were 12. Let's go to 42. 42-year-olds will shop till they drop, but that's at like 3 and we're not going out tonight. Not going to happen. So now let's go out to 62. At 62, we're putting our feet up for a few minutes before we start dinner. We're thinking about retirement because there's just not enough energy in the day to do all of our household tasks as well as work full time. So we're thinking about retirement. We've slowed down. We have less energy. So if we know that the energy levels are going to decrease across the lifespan, what do you think energy levels are going to be like at 82?
Not so much.
Very little. Very little. Now, remember that we tried to tell that 2-year-old we don't have energy and that 2-year-old didn't get it? Right? Well, when that 82-year-old tries to tell you, I don't have that much energy, you're not going to get it. You'll end up saying things like, come on, Mary, just let me give you a shower. I do all the work. When they say they don't have the energy, they mean they don't have the energy. So now we have to start to think about, well, wait a minute, if we know that they have very little energy, we have to start to think about things like, what kind of things do they do every day that take energy? I mean, how are they using that energy up? So let's look at that. What are some things that you do every day that takes energy?
Yes.
Okay. What else?
Bathroom?
Okay.
Eat.
Eat. Yeah. What about getting out of bed? Getting out of bed takes about half of my energy level every day because I like my bed. It's comfortable. And I really have to work hard to get the energy up to get out of it, right? If you've ever used the phrase, I'm too tired to fill in the blank, whatever that is takes energy. Have you ever been too tired to eat?
No.
That means eating takes energy. Have you ever been too tired to talk? I'm like that every Monday and Wednesday because I talk nonstop in here for 4 hours. By the time I get home, I do not want to talk. I just don't want to. I've used up my words for the day. Thank you very much. If you've ever been too tired to, whatever that is, takes energy. Have you ever been too tired to get a shower? Have you ever been too tired to walk somewhere?
Yep.
So we have to understand that things that we take for granted, things that we do without even thinking about it, takes energy. And they're not a big deal for us because we've got big energy levels. But to an 82-year-old, brushing their teeth might feel like a monumental task because they're out of energy. Showering might feel like it's something that they cannot accomplish because they're out of energy. Does that make sense? So we have to be aware of this. It's not as cut and dried as you're going to do all the work, they're just going to sit there. Because even sitting takes energy. Have you ever had the flu and you were laying in bed and just sitting up was too much? That means sitting up takes energy. But even things that we don't think about will take energy. Things like breathing takes energy. Digesting food takes energy. Your heart beating takes energy. And if we've only got this much energy to work with, and we know that all of our body processes are going to require some of that energy, that's going to leave us with very little energy to get through the day. Make sense? Now, there's something else that's going to play into this, something called circadian rhythms. Everybody has a little bit different normal. So, do I have anybody here that's an early bird that likes to get up with the sun, enjoys the birds chirping?
I'm not, but even though my brain wakes up at 3 o'clock in the morning.
Yeah. Yep. So some people are morning people. My husband is a morning person. He gets up at 4:30 in the morning. I think he's insane, but he likes to get up early. I'm more of a night owl. I tend to come alive at night. I do my best work somewhere between 7 and 10 p.m. That's when I am the most productive and the most creative. Don't try to get much out of me before 11 a.m. because you're not really going to get far with me. Right? So I have a little bit different circadian rhythm. Now, you generally learn your own body's natural rhythms as you age. You become aware of when your body operates the best. And you tend to group your activities during times when you are the most productive. Does that make sense? But not everybody is exactly the same. Now, our society is geared toward people that do well during the day and sleep at night. That's how our society is geared. That doesn't mean that everybody is geared that way, though. Bless you.
Thank you.
So if we have somebody like me who does better in the evenings, and you've got that person on an early morning shower schedule, that like 6:30 in the morning, they're scheduled for showers, but yet they do better in the afternoons or evenings, do you think that person is going to want to shower early in the mornings?
No.
No, so they're probably going to say things like, I don't want to shower. Now, as a CNA, we're ruled by schedules. We want to get all of our work done in a timely manner. And when you have to argue with a patient, like, I have to get you into the shower, be cooperative, please, and you get very frustrated with them, that's just going to make them dig their feet in a little bit more. So it's helpful to us to learn your patient's normal rhythms. And it might be worthwhile to go to the nurse and say, hey, listen, Miss Mary's on the morning schedule, but she doesn't do real well in mornings. Can we switch her to a night shower schedule? You guys are going to be the ones that are most in tune with your patients. You're going to know things about the patient that the nurse just simply doesn't know. So passing these observations off to the nurse becomes a very important part of your job. Because Miss Mary might say yes to showers a little more often if they coincided with her energy schedule. Make sense? Okay. Another part of this whole topic revolves around energy conservation. And that's because that little bit of energy has to get them through the entire day. And what you'll notice with older people especially is they tend to like their bigger meals earlier in the day. So what we would consider lunchtime would be a larger meal. And for dinner, they might just have a little something. Their appetites might not be very good in the evenings. When we traditionally take our biggest meal in the evenings, a lot of older people will just want something light. And that's because digestion takes energy. And if you eat a big meal and then go to bed, it may take more energy than the body has to give, so that food just kind of sits there and doesn't get processed well. And that can lead to indigestion and an aspiration risk and GERD or esophageal reflux disease and things like that. So it also takes energy to eat. Just active eating takes energy. And if our patient has used up all of their energy by the time they get to the dining room in the evening, they just might not have the energy to eat, much less digest. I mean, that doesn't even play a part in it. They don't even have the energy to eat right now. So things that we can do as caregivers to help them conserve their energy can help with their overall life balance, just their overall ability to get through the day. Does that make sense? Mm-hmm. If we have a patient that's consistently too tired to eat every night and they're not taking in good nutrition, what do you think is going to happen to their energy level tomorrow? Yeah, it's going to be even less. And this causes a downward spiral that we actually have a term for. It's called failure to thrive. So what we do as CNAs is actually very, very important to the overall well-being of our patient. We have to be aware of this. Make sense? So there is a relationship between strength and energy. When we have a lot of strength, the energy level required to do something is lower because we have strength. But if we have less strength to do something, the energy required to do that task has to go up. Make sense? Now, last week, we talked about the effects of aging. And one of those effects was a decrease in muscle strength. So our older patients have less energy, but they also have less strength. And that can make it very difficult to do very simple things. Let me show you what I mean. Have you ever seen an old person try to get out of a chair? Ever see that? Call it the rock and roll method. Because an older person that's sitting, when they try to get out of a chair, it's going to require energy because they don't have a lot of strength in their legs. So they end up doing something like this. Start to rock. And then they get up and no, back down. Then they rock a little more. And then they How much energy did that take?
Almost 100%.
Took a lot of energy. Took way more energy than if the patient had just stood up, right? Now, we don't stop to think about this because remember, we're on the other end of that energy scale. We've got lots more energy than our patients do. So we don't really stop to think about this. So if we know there's a relationship between strength and energy, we know our patient is low in strength and low in energy. That means that we have to give them either strength or energy from another source. Let's think about how often that patient has to get out of a chair. Remember, that took a lot of energy, right? Just getting out of the chair. So when we wake up in the morning, we got to get out of bed. That's a lot of energy. We have to go to the bathroom and sit down on the toilet, then get off that toilet. Then we have to brush our teeth, and by now we're probably pretty tired, so we sit down in the chair to rest. Then we have to get up out of the chair to get dressed. And then we sit in the chair and wait for somebody to come take us to the dining room. So we have to get up out of the chair, walk to the dining room, sit down in the chair to eat. After we eat, we get up out of the chair, walk back to our room, and go to the toilet. We have to get off of the toilet and then probably go to an activity where we sit down. And then we have to get up to go to lunch. And we sit down at lunch, and then we have to get up to go back to our room to go to the bathroom. Then we get off the toilet, and then we go lay down for a little rest. And then we have to get up and go back to the toilet. Do you see how many up and downs there are? And remember how much energy each one of those took. So if we can do something to help our patients conserve some of their energy during each one of these ups and downs, it might be useful from an energy conservation point of view. So when we have a patient who is struggling to get up, we can help them with that by using a gait belt. This is going to go around the patient's waist, and it allows me to use some of my strength to reduce the amount of energy required by them. Remember, strength and energy are related. So if I use this gait belt and put it around my patient's waist, I can use some of my strength to help them stand. And now they're not putting out so much energy with each of those movements. Good? Make sense? Okay. So this is not a restraint. We do not ever use a belt to tie a patient to anything. Anything. So if you see somebody using this to tie a patient to a wheelchair, that is a restraint, not allowed. If you use something like this to tie a patient to a chair to keep them from wandering, that is a restraint, not allowed. A lot of facilities do not let CNAs use gait belts now because a lot of CNAs out there have used them as a restraint. But they're useful to help with energy conservation. The problem is if we don't have a gait belt and we have to help this patient stand, we only have two choices. We either grab them on the backs of the arms and pull. Well, when you do that, when you grab somebody by the back of the arm and pull, you're pulling their upper body. Their lower body is trailing, and most of our weight is in our lower body. So that means we have to grip harder and pull harder, which is probably going to injure the patient. So grabbing by their shoulders or their upper arms does not really help, and it actually increases the risk of injury. We don't like that. So some CNAs along the way have said, well, you know, we should be lifting at the center of gravity, which is absolutely correct. But without a gait belt, the only way to lift at the center of gravity is to grab their pants and lift them with. Anybody ever have a wedgie? Because this is a monster wedgie, and your patients will move, and man, they'll move quick. But they're moving because you're hurting them, not because you're helping them. So in order to keep us from grabbing the backs of the arms and injuring the patient, or grabbing their clothing and injuring the patient, we use the gait belt, but it has to be used properly or your facility will take it away. And that just unfortunately affects the patient. Good? You guys understand a little bit about energy conservation and why we would need it? So last class, we started learning about shoe rules. We learned that if the patient's feet hit the floor, we talk about their shoes. We should not be walking anybody without shoes. We also learned that slipper socks are not enough. So we're going to finish these now. If you look on page 67, the care plan at the top of the page says to ambulate the resident at least 10 steps. Use a gait belt or transfer belt. Patient will be sitting in chair at side of bed with shoes on. Patient is able to walk, but needs assistance to stand. Everybody good with that?
Mhm.
Any questions on that care plan? 10 steps is round trip. That means we go 5 steps in one direction and 5 steps back. For the test, they're going to give you a destination. They're going to say, walk to the wall and back, walk to the door and back, walk to the desk and back. They're going to give you a destination. Good? It's going to be at least 10 steps round trip. Might be a few more, depending on the length of stride of your patient. But the reason that they give you a destination is because they're going to trick you. For the test, they're going to put something in that path. They are going to put an obstacle in your way on purpose because they want to make sure that you look at that path for any obstacles before you stand the patient up. Because if I stand this patient up and we get to here and I say, oh, hold on, stay right there. Let me go move that thing out of the way. That's right. We're now not monitoring the patient. If I try to maneuver the patient around the obstacle, I'm risking injury. So they are going to move, most likely, a rolling table like this directly in the path of where they're telling you to walk. It's up to you to look for that obstacle and move it out of the way before you stand the patient.
Okay, so you now complete the patient, you introduce yourself, and then just say, hold on a minute, I'm not sure nothing is in the way.
Yeah. So before I go wash my hands, I'm moving that table.
Okay.
Good?
Mm-hmm.
All right. Not too many supplies for this one. Patient needs shoes, which you'll already be wearing. We don't even have to put shoes on for this. They're already wearing them. We're just going to mention, I see you have shoes on. And you need a gait belt. Gait belts are going to be in usually around the supply cabinet, sometimes on a hook hanging off of the supply cabinet. But the evaluator will show you where to find the gait belts before you start this skill. Make sure you use one, and we have to use it properly. Now, I told you that this goes around the patient's waist. I'm going to show you on me just to show you, but this goes around the patient's waist. It does not go way up here. It goes around the waist. And we want it snug enough that it's not going to move when we try to lift the patient with it. If we have this on too loose, it's going to go up underneath the breasts or under the arms, or the patient may just slip right out of it. So we want to make sure that it's snug enough. And I'm going to show you how to check to make sure this is snug enough. So this goes around the patient's waist. Now, it doesn't matter whether the buckle faces this way or the buckle faces this way. Nobody cares. What matters is the tag is on the inside, just like every other article of clothing. Right? We wouldn't put a t-shirt on with the tag sticking out. You would know it's inside out. So tag inside, just like clothing. When you put this around the patient's waist, you want to make sure it's not twisted. It's got to be flat around the patient's waist. So this goes around the waist, just like that, flat. Once you get this around the waist, all right, Jake, go ahead and zoom me in.
Oh.
Once you get it around the waist, this free end goes through the first guard by the alligator teeth. So I'm going to slide this right in through that guard. Now I'm going to hold this tail and pull it in the direction those teeth are pointing. See how the teeth are all pointing that way? All the points are pointing that way. I'm going to pull this in the direction those teeth tell me to. And I want to make sure that it's snug. This is not snug enough. You should only be able to fit 4 fingers between the belt and the patient. That's way more than 4 fingers. So you want to keep making this snug until you can only slide 4 fingers. Now I can't pull that belt away. This is snug enough. It's not going to move. Now I have to lock this tail in so it doesn't move, because right now, I can make this move. So once you get it snug enough, check with 4 fingers, you put that free end, that tail, through the second guard to lock it in place. Now that tail is going to hang down. If it's too long, just tuck it up in the belt to keep it out of the way. Good. To take the gait belt off of the patient after you're done using it, it's not exactly the same. We're going to take it out of the second guard, just like we put it in. But this time, instead of pulling the tail, we're going to pull the buckle. So we're going to hold the tail straight, and we're going to slide the buckle along the tail. To put it on, you hold the buckle and you pull the tail. To take it off, you hold the tail and pull the buckle. Then you're going to slide it out of that first guard. Now, the way you take this off matters. We don't want to slide it against the patient's clothing or skin. Listen to the sound. You hear that? That can actually burn me. So we don't pull this against the skin. You either reach your hands behind and grasp it to take it out, or you can loop it over the patient's head. Either way is fine. Don't let that buckle hit the patient's head. Make sure you have control over it. Good. So that's how we put a gait belt on, and that's how we take it off. Questions so far? Okay, so now let's talk about body mechanics. Okay, zoom me back out, please, Jake. Thank you. I'll need you to focus on my feet in a minute.
Okay.
So remember, if the patient's feet hit the floor, we have to talk about their shoes, and slipper socks are not enough. Thankfully for the test, patient already has shoes on. We're just going to say, I see you have shoes on. Or are your shoes fastened appropriately? Or do your shoes fit well? Something that lets those evaluators know that we know shoes are important. Once we do that, and we know slipper socks are not enough, we're going to put the gait belt around the patient's waist. Remember, this patient is sitting in a chair at the side of the bed. So we're going to put the gait belt around the patient, checking to make sure that we can only fit 4 fingers between the belt and the patient, and make sure it's secured properly. We have to make sure the patient's feet are flat on the floor. Now this actually takes some work on your part. And the reason is, all right, Jake, you're going to want to fit on my feet here. The reason is, can you see my feet? Okay, I can't turn around. All right, my feet look like they're flat on the floor. The problem is that I'm short, and my feet actually do not go all the way to the floor. The tips of my feet do, but I am not flat on my feet right now. So in order for me to get my feet flat on the floor, I have to scoot my body forward a little bit to get my feet to touch the floor. Does that make sense? Normal sized people don't have this problem. But even a normal sized person might have a long torso and shorter legs. So you can't take this for granted. You have to make sure the patient's feet are flat on the floor. If I scoot back here and my feet are not completely flat on the floor, what's going to happen when you pull my body weight forward? Yeah, I'm going to tip forward, and that means that I'm likely to fall or I'm going to injure you. So making sure this patient's feet are flat on the floor is a critical checkpoint, because this is what's going to help reduce falls. So you have to say, are your feet flat on the floor? Do you guys understand why? Okay. So now that we have our patient's feet flat on the floor, just leave it there for a minute, Jake.
Okay.
We're going to have our patient count to 3 before, or I'm sorry, we're going to count to 3 before we lift the patient to have them cooperate. So I've got my, I'm going to show you body mechanics in a minute. I got my arms around the patient, grabbing onto that gait belt, and I'm going to say 1, 2, 3, and then we're going to stand together. They're going to lend whatever strength they've got. Now I'm going to use some of mine as well. But if you just grab the patient and try to lift them and they're not cooperative, they don't know it's coming, they may stiffen up or fight you. It's not going to go as smoothly. So we have to make a patient a partner. Now this is what I've got to show you. If you've worked in healthcare previously, you were probably taught to do something that we don't do. We have to make sure this patient's feet don't slide out from under them when we stand them up. Because remember, it's our strength that's pulling them upright. We don't want their feet to slide out. Well, we used to teach people to go knee to knee and toe to toe. So I would stand in front of this patient who's sitting in the chair. I would put my knees against theirs and my toes against theirs and lift them up. The problem with that is when you're knee to knee and toe to toe, there's a physics principle here. Every action has an equal and opposite reaction. So if I've got somebody sitting in this chair and I am pulling them toward me, all of their body weight is forcing mine backwards, and all of that weight has to be accommodated by my lower back. And that's how back injuries occur. We don't want to stand in front of somebody. Jacob, can I have you come sit in this chair, please?
Yes, ma'am.
I just need your feet.
Okay.
What's that?
No, it's cold.
It's cold in here?
Yeah.
I'll
Okay,
turn it up in a
we'll
second.
turn it up. All right, so if I'm going to lift Jacob to a standing position and I've got a gait belt around his waist and all of that, I don't want to stand right in front of him to do that. I'm going to stand at an oblique angle. And if you see the way he's sitting, the way his feet are, I could draw a box around him. So straight line on each side of the chair and a straight line right in front of his feet. I'm going to use that box for body mechanics. I'm going to take one foot and put it in front of his feet across.
You want me to square my feet?
No, you're fine. 1 foot in front of his feet. The other foot is going to go beside the chair, parallel to him. So I would be standing at the corner of the box. And when I go to lift him, this gives me a lot more stability. So 1 foot here and 1 foot here. I'm going to reach around behind him to grab the gait belt. He's going to put his hands on my shoulders. I'll talk about that in a minute. And I want to bend at the knees, not the waist. So I would be like this. And then I'm going to stand him. Well, when I stand him, his hands would be up here. I'm going to step back with this foot. And that keeps me very stable. You guys see how that works, that oblique angle? Thank you. You can go ahead and have it. And you can return our video.
Camera back to 1.
Yep, thank you. Once I've got him standing, I want to ask, are you okay? Are you dizzy? Feeling all right? Something like that. I don't want to wait until we're way over there. Because if I ask him when he's way over there, he's like, yeah, I'm not feeling so good. What are my options? Yeah, we're in trouble. If I stand him up and I ask him here, are you feeling okay? And he says, no, I'm really not. I'm a little dizzy, a little woozy, a little nauseous. He's sitting back down. We are not going anywhere. Have a seat. Here's a call light. I'm going to go find a nurse. Not my problem. Right? Make sense? So when we stand somebody up, we give them a second to acclimate, and then we can walk, or we ask them if they're okay, and then we can walk them. The whole point of walking, this is such an easy skill, guys. We're walking somebody 5 steps, turning around, walking them back to the chair. It's not the walking that they're grading you on. It's the safety. Every single one of these steps is safety. Does that make sense? So every single checkpoint is going to count big on this one because it's all safety. So we get the gait belt around the patient, make sure it's 4 fingers only, tighten it enough. We make sure their feet are flat on the floor. We're standing at an oblique angle. We put our hands around their waist, grab the gait belt on the count of 3. 1, 2, 3. We lift, we stand. We ask, are you okay? We walk, we turn, and we walk back to the chair. The only part of that they're looking at is, where is your attention? If you are paying attention to the patient, you are on track. But if you are looking at anything else, that means that something could happen to this patient and it would be on you. Now let me explain to you why that is. Why are they looking at that? Because the number one injury that happens to patients in a clinical setting is a fall. And it's universal. CNAs will always say, I don't know, we were just walking along, everything was fine, and then they were on the floor. That is not what happened. I can guarantee you that is not what happened. That patient gave you all kinds of clues that something was way off in their world. They got wobbly, they got pale, they got sweaty, they put their hand out for stability, or they put their hand here or here. They slowed down. They gave you a million nonverbal clues that something was going wrong. You didn't pick up on that. And because of that, the patient is now on the floor, injured. You guys see how that could be a problem? So when you are walking a patient, your entire focus needs to be on that patient, which is why we had to remove the obstacles before we stood the patient. Because if I'm looking at that obstacle, where is my patient not, or where is my focus not at?
The patient.
On the patient. And that's what they're looking for here. Does that make sense? So we have to understand that this is where your patient is most at risk, is when we're walking them. That's when falls occur. And that's the number one reason for injury for a patient, is a fall. So let's talk about what happens, though, if your patient does get dizzy or weak or nauseous or pale or sweaty or wobbly or any of the other symptoms that's telling you something is wrong. What if they do display those symptoms? Well, the very worst thing you can do is try to rush them back to their chair. And that's what CNAs generally do. I don't want you to fall. Let's get you back to the chair. Hurry, hurry, hurry. Your patient isn't tolerating a slow walk. They are definitely not going to tolerate a rush, rush, rush. You're not going to get them back to the chair. And that is where falls happen. Falls generally happen when a patient is trying to be rushed back to a chair after the CNA has identified a problem. So we can't get them back to the chair. That's not going to happen. We don't want to leave the patient standing there wobbly, because they'll definitely fall then. So you don't leave them to go get a wheelchair. calling somebody for help, that's not going to materialize in time. So what do? Can't get them back to the chair, can't leave them, can't call for help. So what do? We sit them on the floor, because a patient that's sitting on the floor can't fall on the floor. I can wash off anything with soap and water except a broken hip. Make sense? So if we're walking and our patient gets a little squirrely on us, the way that I'm walking allows me to accommodate that. So if I'm walking a patient, they need to be slightly in front of me, off to my stronger side. If I'm left-handed, I'm doing this. Okay, I'm on my stronger side. If I'm right-handed, I've got the patient over here. So I've got my hand in an underhand grip on that gait belt. And remember, it's snug enough that now I can feel if they get a little squirrely on me. And I've got that gait belt in my hand. When we're walking, if this patient gets a little squirrely on me as we're walking, and where's my focus?
The patient.
On the patient. So we're walking, patient gets a little squirrely. This leg, my stronger leg gets planted right in between theirs. This hand grabs the gait belt. And now I can easily pull them against my body for stability. Are we okay? We're going to slide to the floor. Ready? 1, 2, 3. And we're going to slide to the floor. My stronger leg. That's why you want to be with a patient on your stronger side, because your stronger leg is going to help you lower that patient to the floor. Then you can yell for help and get somebody to go get a nurse. Good? That will be a written test question. What do you do when a patient starts to exhibit signs of weakness, nausea, dizziness, whatever, while you're walking? You help them to the floor and then call for help. Good. You never, ever, ever try to return them to the chair. Never try to return them. They're not going to make it. They're not. And please don't ever leave them. So I want to explain to you something called a critical concept question on the state exam. So during the written test, you know you got 60 questions. They have to answer. They're all multiple choice. 60 questions. Only 50 of them are actually graded. 10 of them are what they call pilot questions. They're testing them out for use on a future test, making sure that the majority of people are able to identify the right answer. Good? Makes sense? So out of those 50 questions that count, there will be 1 or 2 questions that are considered critical concept questions. Now, what does that mean? That means that if you select a specific answer, it is an automatic fail. It doesn't matter how many other questions you get right. If you got 49 right, this is the only question that you got wrong, but you picked a specific answer, it's an automatic fail. So I want to explain to you why this occurs. There's usually 1 or 2 questions, that's it. But on that particular question, it's not enough to get it right. You have to avoid the answer that puts the patient in immediate mortal jeopardy. These are always emergency questions, always. Because CNAs have been trained that we follow the care plan or we notify the nurse. Those are our only 2 actions we can take. That's it. We don't make decisions, right? But in an emergency, you don't have time to go to the nurse. You have to act. Emergencies require immediate action. So now we're making decisions. Make sense? Okay. So in an emergency, we have to be able to act. If we take an action that puts our patient in immediate mortal jeopardy, you cannot be a CNA. So let me give you an example. You walk into a patient's room and you notice that there is a fire burning in the trash can next to the patient's bed. It's a very small fire, confined to the trash can. Do you A, get a fire extinguisher, B, notify the nurse, C, move the patients out of the room, or D, pour water on the fire? Okay. If you chose go get the nurse, that could potentially fail you because you're leaving a patient and fire in the same area. That puts your patient in mortal jeopardy. Does that make sense? So there is one, sometimes two questions on the state exam that there's one specific answer that could really cause very bad results on the test. Remember, they're always emergency questions. So what kind of emergencies would it be? Well, there's chest pain. Chest pain. What do you think we should do with chest pain?
You just call for help.
Yeah, we're going to get help right away. We're not going to lay the patient down, give him an antacid, check on him in 15 minutes. We're going to act. So another emergency would be choking. If a patient is choking, what should you do? Yeah, abdominal thrusts. We want to get that choking, whatever is in that airway, that obstruction out. So yeah, once we get that obstruction out, we would lay them on their side, absolutely. We would not call 911. That would be an option. We would not call 911 because your patient is still choking. We have to know what to do there. CNAs don't call 911, by the way. You guys know that? CNAs do not call 911. It's not your role. What is the whole purpose of calling 911? Okay, but who are we trying to get? Ambulance or police, right? So that's why we're calling 911. So if this is a police problem, yeah, you could call 911, but if this is a medical problem and you're trying to call an ambulance, why are you calling an ambulance? We have better trained people than the paramedics right in the building. So CNAs do not call 911. Why would you do that? Nurses have more training. So it's like you're calling the wrong people. Does that make sense? Nurses or CNAs do not call 911. If you think that 911 needs to be called, you need to let the nurse know. The nurse will make that determination. Good. There are people in the hospital that call 911. Where do you think the ambulance is taking you? You're already here. Okay. Do you know why they call 911 from the hospital?
You're in green to be taught.
Okay, you're ingrained, you're scared, but you're, say it loud.
No one's helping.
No one's helping you. You hit the call light, nobody came. So who do you call? Right? CNAs do not call. So that's not an answer, guys, on the exam. We don't call 911. Do you guys understand about critical concept questions, though?
Yeah.
How one question can fail you on the state exam? Pay attention to, I think it was chapter 3 talked about emergencies in your book. You might want to go back and review that. Bless you.
Thank you.
Because you will have an emergency on the state exam. Fire is very common. That is the most common question. The way to remember what to do with fire is RACE. Yeah, race. We remove. Patients and fire should never be in the same place. I don't even want to be where the fire is, right? I don't think people and fire should coexist. So we're going to remove the patients. We're going to sound the alarm, activate our emergency system. Somebody else needs to know there's a fire here. If you want to play Freddy Firefighter, that's fine, but let somebody else know first. Then we're going to contain it. Now, something that most people don't know about clinical settings like hospitals and rehabs and stuff, they're built in a very specific way. There are firewalls in between every so many rooms. I think it's a pod of 4. There has to be firewalls. So when a fire exists in one section, we can close off the doors of that section and that fire cannot spread from that section. It is compartmentalized. So containing the fire becomes very important. That's why if you're in a clinical setting and a fire alarm goes off, all of the doors in the middle of the hallways will all slam shut. And that's to contain the fire in that section. And then if you want to play Freddy Firefighter and you've been trained to use a fire extinguisher and you have one in your hand, then you can go in and try to put the fire out. But don't put the fire out until you've done all the other things. Good? They don't pay me enough to play Freddy Firefighter. But I do know in this room, if a fire should break out, I do know that I can pull the pin, fire extinguisher's right back there. I can pull the pin, aim at the base of the fire, squeeze the trigger, and then spray. So I do know how to use it. Should one come along. That's going to be part of your orientation. Wherever you go to work, you are going to have to go through an orientation period. And during orientation, they are going to train you how to use a fire extinguisher. All right, so we want to ask if the patient is good. Now, once we're done with the walk and we're going to help our patients sit down, you want them to turn around so their butt is facing the seat in a normal sitting position. So you're going to turn them around. But I can't feel that. I have no idea if that chair is behind me. I'm not against that chair. Do you think I'm going to have a high level of trust in you? No. Chances are I've been dropped before. So when you are going to sit a patient, you ask them to back their legs up until they can feel that chair behind them. And then you're going to help them sit. Don't ever ask the patient to trust you. They have no reason to. So we have to make sure they can feel that chair behind them. We're going to use those same body mechanics. They'll put their hands on our shoulders. We'll grab around the gait belt. We're going to help them sit the same way we stood, using that same oblique angle. All right. So the first thing that we do with this skill is we remove any obstacles. We want to make sure that, and that's what they're going to put in our way, is a tray table. Because it's on wheels, it's easy to move, it's big, it's obvious. So that's what they're going to use. Just look around for the table if you get this skill. Move that out of the way first. I don't care when you do it. Don't care when you do it. Do it before the opening if you notice it. Do it after the opening before you wash your hands. Do it after you wash your hands. Do it after you get the gait belt. I don't care when you do it except before you stand the patient.
They're going to tell you where you're going before you.
Right. Before you ever start the skill. The care plan says what it says on that page. You walk the patient at least 10 steps. But they're going to give you a destination. So if I were the evaluator for this skill, okay, so you're going to be the patient, you're going to be the CNA, so patient comes sit in the chair, and you can just stay there. Patient comes sit in the chair, you come over here,
here is your care plan. I'm going to read it to you. Here it is. And start whenever you're ready. So I put that over there. It just looked like I was cleaning the environment. I did that absolutely on purpose because I'm going to tell you, I want you to walk to the door and back. They're not going to do it in a way that you'll pay attention to it until you know to pay attention to it. Now that you know that they're going to be doing that, you're going to watch for it. Good. So the first thing we do is remove any obstacles. Then we're going to make sure your opening is done and all that. We'll put the gait belt over. This is a checkpoint. Put the gait belt over patient. That's a checkpoint. Put the gait belt over the patient's clothing. That tells you that people have put the gait belt under clothing. If it's a checkpoint, it means enough people have done that to make it a checkpoint. That to me is just like,
Painful?
Don't strip your patients before you walk them. That's crazy. But the gait belt goes over the clothing. We're going to hold around the sides or the back of the gait belt to lift our patient. Never lift from the front. Don't pull the patient. Sides or back. And when you stand them, you want their hands on your shoulders. Do you see? Her hands are on the side. Do you see how far back her torso is leaning? Because it's not moving her as a unit. When she puts her hands on shoulders like this, not around the neck, just lay the hands on the shoulders, it moves that torso as a unit. So it's less likely for the patient to fall backwards. Does that make sense? We're going to let the patient lead. We'll walk slightly behind and to one side, having an underhand grip on that gait belt. We'll monitor throughout the skill. Are you dizzy? You feeling okay? And then once we get back to the chair, we're going to have them turn around so they can feel that chair behind them and then help them sit using the gait belt. We'll take the gait belt off, not sliding it against the skin or the clothing. And then we're going to make sure the patient is properly seated. Thank you for the thumbs up, guys. All right, questions on that one? Questions? All right.
Video?
No, I'll do this one live. Jake, come sit. I know.
Guinea pig.
He hates it when I do this. Oh, you know what?
You want to move the camera down?
You're going to have to follow me.
You got it.
Hold on, we're setting up the camera.
Why is it not going into follow mode?
Okay, can you follow me manually?
Yeah.
All right.
Maybe. It's not. Well. There we go. Okay.
All right, let's see.
Step back into frame for me, please. All right. Now try. What is?
It is.
There we go. Hold on. Let's see. It's on follow mode. Oh, that's why I'm hitting the wrong button. That's why. Okay. Now you're on follow mode.
No.
I just, what? Step back into frame for me, please. All right. I'm hitting follow mode.
Okay.
All right.
Follow me.
It was just
Yay.
being difficult.
Okay. There we go. All right, so this is ambulate with a gait belt. We've read our care plan. We know what to do. The evaluator has put this in my path and has instructed me to walk to the door and back. I will simulate hand washing. Good morning, Mr. Jones. How are you?
Doing well. How are we today?
Fantastic. Do you feel like going for a walk?
Sure.
Okay, I'm gonna close your curtain, wash my hands, get my supplies, and I'll be right back.
Okay.
So I'm gonna close the privacy curtain. We'll move this out of the way. Wash my hands, I have clean hands. And I'm gonna place the gait belt around your waist. This is gonna help me lift you to a standing position and provide a little stability while we walk, okay?
Okay.
So I'm just going to slide this behind you and relax your arms. I'm gonna put this through the first guard by the alligator teeth. We wanna make it snug, 4 fingers. We'll lock it in through the second guard. I'm just gonna tuck that out of the way. All right, Mr. Jones, can you put your feet together for me? And I'm gonna ask you to put your hands on my shoulders in just a moment. On the count of 3, we're gonna stand up, okay?
Mhm.
So 1 foot in front, 1 foot beside, put your hands up there. And on the count of 3, 1, 2, 3. Good?
Mhm.
Okay.
Sorry to dead fish on you there. I just
That's
wanted
okay.
to show the process.
Are you dizzy at all?
Nope.
Okay, so at your pace, I'm gonna have you walk to the door.
Okay.
So I'm gonna hold in an underhand grip. Okay, go ahead and turn around. And we'll walk back to the chair at your pace. Okay, now turn around, back up so that the back of your knees hit the chair.
Mhm.
You're gonna put your hands up here again,
Feel
and I'm
the
gonna
chair?
help you sit. Yep, can you feel the chair?
Mhm.
1, 2, 3. Good. Okay, remember to take it off. We pull the buckle. I'm going to lift this over your head. All right, are you comfortable?
Mhm.
Is there anything else I can get for you while I'm here?
No, thank you.
Would you like a magazine before I go?
No, thank you.
Let me get your call light for you. Here's your call light. If you need anything at all, just let me know. I'm going to open the privacy curtain. Wash my hands. Think about my skill. My skill is done. Thank you. Any questions? No questions? All right, while you're up, please pass out washcloths.
Washcloths.
Oh, it's gonna follow you now.
Where's the remote?
All right.
Yeah.
Okay, so Jake's passing out washcloths so we can learn this for partial bed bath. This is on page 126. This is the longest skill we have. If you look down here at the testing information, somebody with your level of experience should be able to do this skill in 19 minutes or less. 19 minutes. Range of motion is only 4. This is a super long skill. The good news is if you get this skill for the state exam, you get 2 short skills to go with it. A range of motion and respirations. So, or I think it's pulse or respirations, I can't remember, but a very short skill. So if you look down here, you'll see this is going to be done on a mannequin. We're giving a bed bath, so we're going to do this on a mannequin. It's one of 4 mannequin skills. That mannequin will be positioned in bed. You still have to talk to the mannequin like she's a real person. You will get an answer. The evaluators play the voice of the mannequin. So you don't have to play both parts. It's still awkward talking to a big Barbie doll, but you still have to talk to her like she's real. Charting is not required. If you look down here, almost every single principle is used in this skill. They're all spelled out for you here, but we know them all. There is nothing here that we haven't learned except for one thing. This is the very last principle. This is it. And then you got that entire back wall done. So if we look up here on the top of page 127, the care plan tells us to give the resident a partial bed bath. So stop there, time out. Partial means not full, right? Not complete, partial. Well, if I tell you to do something partially, you need to know what parts do you need to do. So this care plan is very complex.
It tells us to give the resident a partial bed bath and a back rub. We know it's partial, it's got to tell us what parts. So it says to wash the resident's face, neck, chest, abdomen, back, and one arm and one hand. Good. It also tells us to provide a brief back rub with lotion. Dress the resident in a clean hospital gown after bathing. Patient is lying on back in center of bed and can roll as directed, but is too weak to assist with bathing. It also tells us here to wash with soap and water. In most hospital settings now, we do not wash with soap and water. We are washing with specialized wipes that contain a bactericidal barrier. So it actually creates a barrier on the skin to keep pathogens from invading. So in a clinical setting, you're going to get a wipe packet, special wipes, and there's usually 5 wipes in the packet. The packet actually tells you exactly what to use where, how to do the cleaning, and they're usually kept in a warmer, because nobody wants to be washed with cold wipes. So they're usually in a warmer. You go by your facility policy wherever you work as to how to do the skills. But for a long-term care setting, soap and water is generally what we use. So we already know the washing rules. We've learned those. We've learned that if the patient's uncovered or undressed, we need a privacy blanket. We know to put a barrier on the table before we put our supplies there. We know if we're going to turn the patient over, we're going to scoot them toward us first. We know that we check the water, they check the water. We know how to clean the bait. There's nothing to learn here. Lots of supplies. You have to memorize your supplies. Flashcards help with this. If you haven't made your flashcards, you need to make your flashcards. Flashcards help with this. But there's something here that I have to teach you, explaining how to wash the patient. And that's this principle. Like I said, it's the very last principle that we have to learn. And this is in washing rules. We're going to use the leaves method for wet body openings. So let's explain what I mean by that. To review washing rules, remember that basins are no soap zones. We need those basins to have clean water for rinsing. So don't add the soap to the basin. We're going to add it to the washcloth after wringing that washcloth out really, really well. When we get water, we use a paper towel to turn the faucet on. We check it, they check it. Make sure it's warm, not hot or cold. We're going to check it with the inside of our wrists. We'll have the patient check it, and we're going to change out water if it gets cold or soapy. We're going to wash and rinse and dry each body part indicated in the care plan, with the exception of the care plan tells us to wash the patient's face, but we don't want to wash the face with soap. Soap dries the skin and it can get into the eyes and sting. So water only on the face. So we're going to rinse and dry the face, not wash. We're going to wash everything else. So face first, no soap. Oops. Remember to wring your washcloths out thoroughly. We don't want dripping wet washcloths. And when we put lotion on, we warm it up first and then wipe off the excess. And it does tell us to give a brief back rub with lotion. So we'll do that. But this is the one principle we haven't learned yet. So you guys have washcloths that were just handed out to you. These washcloths are just squares. They're usually folded in half and then in half again to make a small square. And we have these in our linen closets at home. But instead of looking at it like a square, I want you to turn it a corner turn and look at it as a diamond. And I want you to position the diamond specifically with the folded corner at the bottom and those free leaves at the top. When you have the leaves pointed upward in that diamond shape,
We're gonna put this against our hand with our thumb holding one corner and our pinky holding the other. So I'm gonna come around and help you, okay? So you want, we're gonna do it this way. We want those free leaves. See how these leaves are free? We want those pointed up. Good. 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 Just like that. Good. Just put your hand like this. See how these free leaves?
Yeah.
Okay, I want those pointed up. Turn this toward you.
Oh, okay.
Okay, pointed up.
Okay.
I'm going to tuck that corner in there. And this corner there.
Okay.
And now we've got free leaves. Good. Okay. So everybody see how to hold this? So we're going to hold it in a diamond shape with those free leaves at the very top, tucking in our two side corners, like this. We're going to use, this is called the leaves method. We're going to use this method. I'm going to show you how to use it in a minute. We are going to use this method if we're going to touch eyes, nose, mouth, genitals, rectal area, wounds, rashes, sores, or incisions. Do you guys remember on class 2, we talked about the chain of infection. All of these were doorways. They're doorways out for pathogens, but they're also doorways in, right? You guys remember that? So if we are going to wash any doorway, we have to use this method. This is called the leaves method, and we use it with wet body openings. So the way that we do this to help prevent cross-contamination is I have my washcloth in my hand. If I wipe an eye, remember an eye is a doorway, enter the outer corner, I don't want those pathogens to be put in the other eye. So wipe and then fold. That traps the contamination underneath. Now I have a new cleaning surface. I can wipe the other eye and then fold that down. And that traps the contamination underneath and gives me a new cleaning surface. I can wash the rest of the face and fold that leaf down. And then the last one, I could do the nose. I always do the nose last because boogers. Okay? So, and then the nose. But I'm not bringing pathogens to the nose because this is a clean surface. That makes sense? So the way that this works, this leaves method, is you have 1, 2, 3, 4, and 5 independent cleaning surfaces that allow you to wash 5 areas without cross-contamination, or take 5 strokes without cross-contamination. All right, any questions on that? That's the only thing that you don't know about partial bed bath. Everything else follows the principles we've already learned. So our care plan tells us, let's read it one more time now that we know this. Give the resident a partial bed bath and back rub. Wash the patient's face, neck, chest, abdomen, back, and one arm and hand with soap and water. Provide a brief back rub with lotion. Dress the resident in a hospital gown, and patient is able to roll as directed, but too weak to assist with bathing. That tells us what we need to know to do this particular skill. And remember, it will be on a mannequin. So we're going to wash the face first, no soap, because soap stings and can dry the skin of the face. We're going to use that leaves method because there's wet body openings on the face. We'll wring our washcloths out thoroughly. And when we move extremities, we support from below with a flat palm. Anything used is going to go back on the barrier. It doesn't go into the basin. We want to keep that water clean, with the exception of a rinsing washcloth. Anything we apply soap to should never go back in the basin. But if we have a washcloth that we use for rinsing, you can use that by putting it back in the basin. You can use it for washing the next body part. So why do I say that? Well, in a perfect world, which we know this is not, in a perfect world, you would have all the supplies that you need for every skill on every patient in every setting, every shift. We do not live in a perfect world. Very often, you're going to go to work and the shift before you used up all the supplies. You don't have much left. So you've got to learn how to do the skills with the minimum amount of supplies available to you. Does that make sense? If you have extra supplies and you want to use separate washcloths to wash and rinse, that's fine. But you can do this skill with 4 washcloths. 1 on the face. Remember, no soap on the face, just water. 1 for, but that's got all kinds of goo on, pathogens. We can't use that one. Let's set that aside. We're going to take washcloth 2, wring it out really well, put soap on it, and we'll wash the neck, the chest, the abdomen, the side, 1 arm and hand. And we're going to set that aside on the barrier because it has soap on it. Then we're going to get our rinsing washcloth, wring it out really well. We'll rinse all of those areas. That rinsing washcloth you can put back in the basin. We did not apply soap. Might have a little bit, but not enough to make our water soapy. Make sense? Good? Now, when we turn the patient over and we go to wash her back, we can use that same washcloth to wash the back. And then washcloth number 4 rinses the back. So you are able to do this skill with 4 washcloths. If you've got 5, hey, that's a good day at work. Means that you have all the supplies you need. That's an awesome day. But you need to know how to do it with 4. Because that's going to be more the norm. Okay, good. I wish I could tell you that we were in a perfect world. We're not. In fact, there are some facilities that when you start work at the beginning of your shift, all of your other CNAs will go raid the supply room and pull everything they need and leave you with nothing. And that's horrible. But it does happen sometimes. I would definitely let somebody know. We're going to wash the back, rinse the back, and dry the back, and then we'll give a little back rub with lotion. When I say a little back rub, we're basically just trying to restore circulation and make the patient feel a little better. This isn't a deep tissue anything. We're not massage therapists. This is start at the bottom of the back, go up in small circles to the shoulders 3 times. That's it. That's all we're trying to do here. Just a little wake up for the blood vessels. Once we have the front of the patient clean, I change the gown out. That way, when I turn them on their side, wash, rinse, dry the back, give them their back rub, all I got to do is tie that gown and I'm done. Now, if you want to wait until the end, if you want to wash the front, rinse the front, dry the front, turn the patient over, wash the back, rinse the back, dry the back, give them a back rub, turn them back on their back, change out the gown, turn them back on their side, tie the gown, you can do that. But that's a whole lot more work for both you and the patient. And we've talked a little bit about energy conservation. We need to be aware of that. So I change a gown before I ever turn the patient over. Helps with energy. We do need a barrier for this skill because we have supplies, so we'll get that barrier first before we gather our supplies. We're going to get some water by using a paper towel, checking the water, having the patient check the water. We untie the gown. And while I've got the patient sitting up untying that gown, I'm going to put a towel on that bed to keep the sheets from getting wet. If you don't put a towel there and those sheets get wet, I can guarantee you those evaluators saw it. Do Do you think they want the patient laying on wet sheets at the end of the skill?
No.
So if you don't use a towel, you better look at that sheet. If it's wet, you probably should say, I would change the sheet. You've got to acknowledge it. We'll put the privacy blanket over the patient and pull the sheet down so that we can get to the areas we need to. We'll undress the patient and put on gloves. Remember, the first thing your gloves should touch is the patient, not the supplies. We're going to clean the face with water only. You can see here I'm using that leaves method. I start inner to outer corner, and then we fold that leaf over. We'll do the other eye with the second leaf, the face with the third leaf, and the nose last. We'll dry all of those areas. Guys, this is the number one checkpoint that's missed. People forget to dry the face. I don't know why, but this is the most common checkpoint that's missed. Don't forget to dry the face. It's that way with mouth care too. Why are people not drying faces? I should make that a principle. Make sure the face is dry. All right. You want to control the towel as you do that. Then you'll just wash the torso, the neck, the chin, the chest, the abdomen, the side, one arm and hand. I don't care how you do it. I don't care how long it takes. Wash the front. Whatever you wash, you rinse. Rinse the front. Whatever you rinse, you dry. Dry the front. And then switch the gown out. Then we'll scoot our patient toward us because we know that's important to keep them in the middle of the bed after the turn. We'll turn them on their side and we'll wash, rinse, and dry the back. Guys, this is a mannequin. She does not stay on her side. I can put her on her side right now. She'll always fall backwards. Mannequins don't stay on their sides. The evaluator knows this. So for the test, when you turn the mannequin on their side, the evaluator is going to reach over and hold that mannequin. You won't even have to ask them to do it. They will just automatically reach over and hold that mannequin. If they don't, for whatever reason, if their brains are like wandering or something, that's a good thing, by the way. You want your evaluator's brains to wander because that means they're not paying that close attention to you because they think you've got it. The last thing you want is for that evaluator to kind of sit up and take note. What is she doing? Because that tells you that that's not a common action that they see. You want that evaluator lulled into boredom. That makes you know that you're doing everything right. Does that make sense? Good. So if that evaluator is just kind of lulled there and not really paying attention, you can ask, can you please hold the mannequin? After that, after we wash, rinse, and dry the back, we will give the patient a brief back rub. A little lotion on the gloves, rub them together. Don't use a lot. The mannequin does not absorb anything. If you use a lot of lotion, and I've seen people go, big mouth, don't do that because that's going to get all over the sheets. It'll stain the towels. Don't do just a little lotion just to reduce friction from your gloves. All right, then we're going to tie the gown, get them back on their back in the center of the bed. Time out. This is the hardest thing you're going to have with this skill. You can get all that stuff. That stuff that I just taught you is super easy. This is where you're going to mess up. When you get that patient back on their back in the middle of the bed, you are going to want to take that privacy blanket away and pull that sheet up. Should you touch that sheet with gloves that have stuff on them? This is where you're going to mess up. Because it's just human nature. You want to get the patient all settled before you start cleaning up, and that's not the way this works. Get the patient on their back in the middle of the bed, keep them covered with a privacy blanket, leave them. Leave them. Because you need gloves on to take all of those used supplies to the hamper. You have to have gloves on to do this. And then once you get that done, you can take your gloves off. But if you take that privacy blanket off with those gloves on and pull that sheet up, you will get a ding, a deficiency for infection control. Does that make sense? This is the hardest thing for students. They want to finish with the patient before they start cleaning up. Don't. Clean up first. Then take your gloves off and finish with the patient. Good? We learned this with bathing rules. We're going to use a paper towel to hold that basin, get our supplies with a paper towel, and open the drawer with that paper towel. Once we have our basin stored, we'll take those gloves off, remove our privacy blanket, and then do our closing. Make sure the patient's in a clean and safe environment. They're covered, they're comfortable, address their preferences. Open the curtain, give them their call light, clean your hands. Charting is not required on this one. 19 minutes. Thankfully, it doesn't take 19 minutes for us to do this, but 19 minutes. Now, I'm going to show you the video for this one because it's got good close-ups, and this is one of the new format videos. So when you see this video, along the bottom, this is what is going to make it a little different than our older videos. Along the bottom, you're going to see a bar. And in that bar is the actual checkpoint that whatever I'm doing on the screen is going to check off. So this allows you, this new format allows you to see the checkpoints, but also see the action that is going to check that checkpoint off. Okay, good? Good? All right, so Jake, if you want to put partial bed bath, it should be our new one.
Do you have the new one uploaded in the files?
I do think so.
It looks like the old one.
Oh, no.
If I go to YouTube Direct. Oh, wait, we won't be able to, will we?
Oh, I don't have it on there.
Uh,
Okay. All right. Well, you can go watch. I'll show you the older one, but you can watch the new one. I thought I had it uploaded. I guess I didn't.
It's uploaded. We just didn't download it on this
I
computer.
brought a.
Hi, Miss Jones. My name is Patty. I'm your CNA today. How are you? Good. I need to do partial bed bath. Is that okay? I'm going to close your curtain. Let me wash my hands, get my supplies, and I'll be right back. For this skill, I'm going to need a barrier for the table. This will give me a clean place to put my clean supplies. For this skill, I will need 4 washcloths, 2 towels, a clean gown, and a privacy blanket. It's a washing skill, so I will also need a basin, soap, and lotion. And I'll need a set of gloves. Miss Jones, let me go get some water. I'll be right back. Miss Jones, is this water appropriate temperature? Okay. And now I'm going to spread the privacy blanket out over you. This will help keep you warm and protect your privacy while we do this skill. I'm going to spread the blanket without snapping or shaking the blanket. And I'm going to pull your sheet down to about your waist. Okay, Miss Jones, I'm going to ask you to sit forward for me in just a moment so I can untie your gown. And I'm going to spread this towel out underneath you to keep your sheets dry while we bathe you. Can I assist you to sit up, please? Thank you. I'm going to untie your gown and spread the towel out on the bed. Go ahead and lay back down, Ms. Jones. Thank you very much. And now I'm going to spread the towel out underneath the arm. I'll remove the gown on the side closest to me, supporting the elbow as I lift it. And I'm going to relocate the gown to the other side of the patient. This leaves the patient uncovered underneath the privacy blanket for bathing. The blanket will keep you warm. Now I can apply my gloves. I'll take the first washcloth and wring it out. And I'm going to use 4 corners. We'll wash the face first, no soap on the face. Ms. Jones, I'm going to wash your eyes. I'll start with the closest eye to me. I'm going to wash from the inner to outer corner. Very gently. And then we'll fold this sleeve over to prevent contamination from spreading to the other eye. Ms. Jones, I'm going to wash your other eye now, inner to outer corner. We'll fold that leaf over, and then I'm going to wash the remainder of the face. Using very gentle strokes and keeping control over the washcloth. We'll fold that leaf over and use the final washcloth for the nose. And then we'll set that aside. I'm going to take the towel and pat dry all areas of her face, making sure not to use too much force. We'll set the towel aside. We're going to take the second washcloth and wring it out. And we'll apply soap to the top leaf. We do not need to use the leaves method because all of her skin from this point is intact. We're going to wash behind the ear, under the chin, across the neck, the upper torso. We're going to lift the blanket to protect privacy but keep the patient covered while we wash down to the abdomen and up the side. Now for the exam, you are going to make sure the patient remains covered until the evaluators ask you to remove the blanket. At that point, you will just continue on. I am going to repeat these actions so that you can see what I have done. I'll remove the blanket for better visualization. Behind the ears, across the chin, the neck, the upper torso, around the breasts, down the abdomen, and up the side. Then we'll clean down the front of the arm, the hand, up the back of the arm, lifting at the elbow, and the armpit last. We'll set this washcloth aside because it has soap on it. We'll take the third washcloth in the basin and wring it out. And we're going to rinse all the areas that we just washed. So behind the ear, under the chin, across the neck, the upper torso, around the breasts, the abdomen, up the side, down the front of the arm, keeping the elbow supported on the bed. We'll rinse the hand, the back of the arm, and the armpit while supporting the arm. The rinse washcloth can go back in the basin for later use. Now we're going to dry all of those areas. So we're going to pat dry or use short, soft strokes, but nothing vigorous. Go ahead and lift your arm, Miss Jones. We'll set the towel aside. Now the patient has a clean torso, so we'll place the clean gown on her. Miss Jones, can you reach your arm through here? I'll help you put your gown on. We'll lift the arm at the elbow, supporting it as we lift. And we'll spread the gown out. Okay, Ms. Jones, I'm going to go around to the other side of the bed now, and we'll dress the other arm. Since the care plan said that we only needed to wash one arm, we do not need to cleanse this other arm. That's per the care plan, but we do need to dress it. So I'll remove the soiled gown, and we're going to place this in dirty linen. And then I'll put the new gown on. Ms. Jones, can you reach through this armhole? Thank you. And go ahead and lift. Thank you. Okay, Ms. Jones, I'm going to ask you to turn onto your left side now. This is going to allow me to wash your back and give you a brief back rub. So I'm going to ask you to scoot toward me, and we're going to roll you onto your left side. Ready? Go ahead and scoot toward me. 1, 2, 3. Now the evaluator will hold the mannequin in place while you complete your cleaning. So I'm going to take the third washcloth, wring it out, and we'll soap the top leaf. I'm going to wash the back of the neck, the shoulders, and the back down to the waist. We'll set that washcloth aside. We'll take the final washcloth and wring it out, and we're going to rinse all of those areas. The back of the neck, the shoulders, and the back down to the waist. And then finally we'll dry all of those areas. The back of the neck and the shoulders, the back down to the waist. Now our care plan asks us to give the patient a brief back rub. So we're going to use a little bit of lotion, making sure to warm the lotion in our hands before we give them a back rub. Ms. Jones, I'm going to give you a little back rub now. I'm going to start at the small of your back and work my way up in small circles to your shoulders. We'll do this 3 times. This is for circulation purposes. 1, 2, one more, and 3. I'm going to wipe off the excess lotion. Now I can tie the patient's gown. And remove the towel that's protecting the linens. Ms. Jones, come on back onto your back, please, and scoot to the middle of the bed. Thank you. I do not want to touch that sheet that's going to go right up next to her face with soiled gloves, but I need my soiled gloves to take care of all of my dirty linens. Ms. Jones, I'll be right back. These items are going to go into dirty linen. Now I'm going to go clean the basin. I'll empty the basin and rinse it, and then pick it up with a paper towel. I'll dry the inside with one paper towel and throw it away, and then dry the outside with a paper towel and throw that away. And I'll get one for the drawer. I'll collect the soap and the lotion, placing them in the basin, and return the basin to its drawer for storage. Paper towels can be thrown away. This barrier is going to be discarded, and now I can remove my gloves. Okay, Ms. Jones, I'm going to remove your privacy blanket now and pull your sheet back up. Are you comfortable? Good. We're going to roll the privacy blanket in a ball so that the trailing edges don't contaminate other surfaces. This will be placed in dirty linen. Okay, Ms. Jones, is there anything else I can get for you while I'm here, such as a magazine? No? Okay, here's your call light. If you should need anything at all, please let me know. I'm going to open the privacy curtain and wash my hands. After washing my hands, I'll think about the steps of my skill, make any corrections, and tell the evaluator my skill is done.
Lights coming on.
Okay. Any final questions on what we've learned today? No? All right. You do have one chapter of homework tonight. It's chapter 7, which is another skills chapter. Just read the paragraphs in between the skills because we're covering skills in class. Jake, did you hand out the
Review sheets?
review sheets?
Yes, ma'am.
Okay. So you have your review sheets. Those of you who are attending virtually, please remember you can access those review sheets on fltraining.com, FLCNA training, sorry.
There's a question.
FLCNAtraining.com. Latchman asks, hey, Miss Patty, I have a question. For this skill, do we need
2 basins.
2 basins, one for soap and one for clean water? That's a great question. And you can use a second basin if you wish. The problem is that everything that we get for the patients to use, they're going to be charged for. And those basins are, in most hospital settings, $30 to $40. Yeah, I mean, that's expensive. They don't go, unfortunately, the hospitals don't go to the Dollar Tree to get their stuff, you know? So we have to be aware that, making smart choices for the patients is important. Think about it for a second. If you went to a restaurant and the waiter said, oh no, we don't have menus here. We give you whatever the chef wants to cook for the day, and we don't tell you how much it's going to charge. You're going to get a bill at the end. Would you be willing to take that chance? Mm-hmm. And yet we do that in medicine all the time. The patient does not get to choose what treatment they want or how much they can afford to pay for it. They get the treatment that is prescribed to them, and then they get a bill at the end, regardless of their ability to pay. And the number one reason for bankruptcies in America is medical. That's the number one reason for bankruptcy. That's horrible. That's horrible. So yes, you could use 2 basins if you want to, but remember that that's going to cause the patient to have an additional charge. So you can do this very effectively with 1 basin, and really that's all we need. Great question. Okay, so you've got your review sheets, chapter 7 homework. Does anybody have any other questions?
She has a clarifying on the same question.
Oh, but on the test. No, test 1 basin is fine. That's all you need. It's all you need in a clinical setting too. Some testing centers do have 2 basins, but I think for the most part, if you try to use 2, the evaluators will tell you only need 1. Just don't put soap into the basin. That's the big thing. Good question.
Further clarification?
School I went to said 2 basins. I'm confused now. If they have 2, you can use 2. If they have 1, don't put soap in the basin. I'm very, very sorry that, that there's some confusion there for you. I don't know. If they have 2 basins there at testing center, then you can use 2 basins. Remember, it's double the cleaning though. You have to clean both. Okay. Remember that, okay, so let me kind of put this out there too, because there's a lot of anxiety when it comes to the test, a lot of anxiety. When it comes to doing things, it's very common for everybody to have a different way to clean their house, or everybody to have a different way of making a peanut butter and jelly. Some people put the peanut butter on first, some people put the jelly on first. Some people use a spoon, some people use a knife. There's differences in the way that people do things. Medicine is no different. At the end of the peanut butter and jelly, you still end up with a peanut butter and jelly. It doesn't matter whether you used a knife or a fork or put the peanut butter on first or the jelly on first. None of that really matters, whether you cut the crust off or not. At the end, you still have a peanut butter and jelly sandwich. And the skills are a lot like that. Is that there's no one hard and fast way. This is the only way it can be done, period, end of discussion. Which is why I try really hard to give you the rationale behind each step. So you can understand this is why I'm teaching you this way. This is the checkpoint that's going to satisfy that. This is why it's best nursing practice. It doesn't mean you can't use 2 basins. Certainly, if you've got them, use them. That's fine. No problem. It's still a partial bed bath. but you do kind of need to know how to do it with one because chances are in a clinical setting, you're only going to have one. So just kind of keep that in mind as you're watching these skills. It may not be demonstrated exactly like another instructor demonstrated it, and that's fine because differences are okay. But you do want to make sure you understand the principles behind those steps. Jennifer says, if you sign up for the state board, how long does it take for you to do the test? So Jennifer, if you go back to last Wednesday, class 4, we go through the test registration process in detail in the last half hour of class 4. But generally speaking, from the time that you register until you're testing, about 3 to 4 weeks. This time of year, more like 4 to 5 because all the high schools and community colleges are graduating as well. And they all need to be tested. But generally between 3 and 5 weeks. Any other questions? Jake?
Nothing yet.
Okay. All right. The rest of the class will be practice for you. You can stick around and practice. If you don't want to practice, I can't keep you here. It's adult education. I'm not tying you to the chairs. You are free to go. But I will caution you, if you are not practicing here, please make sure you're practicing somewhere. That's very important. You do not want the first time you do a skill to be during the test. That is just not good. Not a good idea.
Miss Jennifer said thank you.
Very good. You're very welcome. So if you're not practicing these skills here, please make sure you are practicing them somewhere. It's like going to take your driving test. If you've never been behind the wheel, how likely are you to pass a driving test? Probably not. So make sure you're practicing.
Can we buy the kits you were talking about in cash, or do we have to buy them online?
No, you can buy if you buy them from me in class, they're $50. If you buy them online, they're $64.99. So yeah, you guys will want to buy them from me here or Jake. Yeah, and cash is fine. We also take debit or credit. All right. Those of you who want to buy the practice kits online, Jake has put it up there on the screen for you. But just go to courses.4YourCNA.com/shop and you can buy your supplies there too. All right, so I'm going to go ahead and sign off of our virtual. Thank you guys so much for tuning in. We truly appreciate it. Hope to see you on Wednesday for class
6.
Oh my gosh, we are just flying through this. Hope to see you on Wednesday. Remember, tomorrow is the game show at 11 a.m. And I might do some critical concept questions or dementia questions. I'm not real sure. So I hope to see you there. Until next time, happy caregiving. Bye.